Look straight ahead, nothing but blue skies. Okay, come on.
I can see clearly now the rain. Come on.
Being here.
All right, so
Musical aid.
good morning. Welcome to Senate karaoke. With that, the person with the most energy, Senator Avard, I'd like you to lead us in the Pledge of Allegiance.
Absolutely.
All right, thank you.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
After the hearing, Senator Avard will be dancing, so
I don't
it's
dance.
sing and dance.
I see.
All
I
right.
saw you at the inaugural ball. You do dance.
You know who dances a lot? The governor. Wow.
All right. So with that, we're going to open the hearing on Senate Bill 133 relative to the designation of emergency medical services performed by ambulance service providers as essential services. And the chair recognizes Senator McHugh.
Good morning, Mr. Chairman, and thank you. Good morning, members of the committee. This is what a great committee that sings, says the pledge, and has this many EMS folks show up.
This is every day. This is an everyday occurrence.
This is amazing.
Yeah.
It's so nice to see so many of my EMS brethren here today, and thank you all for coming. Really, really great. What a super showing. I was just in the midst of doing some late night Con Ed that they could all appreciate on Prodigy last night and tracking down an ACLS. Yes, it's that time of year, tracking down an ACLS and PALS instructor card and filing all of that stuff. And thankfully, we're getting ahead of the game because we have until the end of March. So I'm sure some of these folks can relate. So we're here to talk about Senate Bill 133. I am Senator Tim McHugh. I represent District 11, which is Merrimack, Amherst, Milford, and Wilton. And in some of my younger years, I got my start here in New Hampshire on the streets of Nashua and Manchester for Rockingham Ambulance. I'm sure you've heard of them. And this is actually a relatively simple, I hope, I hate to say housekeeping bill because sometimes that's the kiss of death, but we did go through an exercise defining essential services some time ago, and we chose the term first responder, which is very accurate in almost every case, but systems are designed differently across the country and across our state. And in some cases, law enforcement and firefighters are the very first to respond. So we neglected to use the specific language ambulance service providers. And in many systems, the ambulance folks are the first to show up, especially if there's a tiered response system or there's volunteers that respond from their homes, or even have the ambulance or have a fly vehicle or a non-transporting vehicle. They could be the first provider to show up. And in other cases, it could be law enforcement because they're on the road. It could be sheriffs, it could be state police, or it could be fire service. So this was suggested by one of the individuals that will testify, an expert, an EMS educator. So we'd like to add the ambulance service provider language to the list of essential services. I've got some written testimony that I won't go through for sake of time, but for the record, I do. Other states have done it. Texas has done it. Nobody expects to become East Palestine, Ohio overnight and have a mecca of satellite trucks set up in your backyard. But it's those types of situations when they happen that the feds and other agencies look to see, well, what are actually essential services as defined by your statutes? And ambulance service providers need to be in that list for things like that and things that we hope never happen. So that's why we need to put this little bit of correction in the language. And that's why I'm here. And with that, I'm happy to take questions or talk about the relatively small amount of boldface type that's in this fairly short bill. Or I'll pass it on to the folks behind me.
Thank you very much. Any questions from the committee?
Good job.
All right, thank you. But Senator, did you have a question? Did I see your hand? Oh, okay, all right. Just to let the folks know, I do have the sign-in sheet for 133. You mentioned, Senator, that people have signed up to speak. I don't have anyone else actually signed up to speak on this. So if anyone would like to speak on this, you're welcome to. Otherwise, we can go into executive session.
All right. Well, yeah, I would invite Keith Wilding, the director of the New Hampshire Technical Institute paramedic program. Come on, why don't you want to come and join me? This is Keith Wilding from the New Hampshire. Well, I'll let him introduce himself here.
Great, thank you, Mr. Wilding. And I am going to underscore the fact we have 6 minutes before our next hearing, and if we can get this done in 6 minutes, we can probably exec this bill.
I got to get these students back to class, so
All
I can do
right.
it in 3. So I'm Keith Wilding. I'm a paramedic for 25 years. I worked down in Massachusetts as a paramedic. I've been the department chair for the paramedic emergency medicine program here at NHTI for the past 8 years, I think, and with them since 2010. And this kind of came up as a chat when the senator came over to get a tour of our program a couple months ago, and it came up that in EMS or ambulance-based EMS specifically is not necessarily listed as an essential service within the United States, or within the state of New Hampshire, per this RSA. It does call out first responders, and that's great, but it becomes vague. As the senator says, a first responder can be someone can be someone in a police car, can be someone on a fire engine. The majority of ambulance services are fire-based here in the state, but not all of them are. We've got private ambulances that are working multiple 911 systems, and ultimately those aren't necessarily covered. It's vague in the RSA as written. So that was the idea the senator and I talked about, is that kind of clarifying that to list ambulance responders as first responders in the statement.
Great, thank you very much.
No problem.
Thanks, Keith. And yeah, just to recap, a lot of other states have done it. Texas, Montana, Arizona. There's a list in my written testimony that have done it the same way. So I think we
right.
just
Very good.
thanks.
Thank you very much. I'm going to close, if there's no one else, I'm going to close the hearing on Senate Bill 1. Oh, did you have a question?
No, I want to move into exec.
Let's close the hearing on Senate Bill 133.
Motion to move into exec.
Second.
All right,
I move ought to pass on 133, SB
Second.
133.
we got a second. All those in favor on ought to pass on 133, say aye.
Aye.
Any opposed, say nay.
Move into consent.
We got a motion to consent.
Second.
Moving to consent. Are we going too fast for you, Sophie? All right, and Senator Prentice, would you take this out?
You bet.
All right.
All in favor?
Oh, all in favor of consent, say aye.
Aye.
Any opposed? No. Senator Prentice has graciously volunteered to take this bill out.
Motion to move
I've
out of
been
exec.
voluntold, I guess, right? Thank
Anything
you.
for you, Chair.
All right. Hey, thank you. And I want to thank everyone who showed up today. I know, having been on the receiving end of what you do, there's nothing better than to look up and see a friendly, competent face on your worst day. And I know that you guys see people on their worst days. And so thank you very much for what you do. Keep up the good work. And thank you for serving the state of New Hampshire.
Motion to move out of exec.
All those in favor say aye.
Aye.
Aye. All right. This is the first time we are ahead of schedule.
Go, don't correct it.
Do we want to, I know, well, do we,
You're
do,
pulling an Ava.
I know, my goodness, I can't sing. So we've got a few minutes.
That's the compliment.
Yes. Do we want to go into exec on any of the bills that I presented to you? I'm thinking maybe we could do 128.
What's 128?
That is relative to children's mental health services for persons 18 years of age and younger. You ready? No? All right.
Thanks a lot.
How about 255, establishing and developing crisis stabilization services?
We're,
It's,
I'm gonna amend that.
yeah.
So that might take a
we've
little
only
more.
got like 2 minutes.
All right. We'll put those on the back burner.
Kevin. If we have questions about
Sophie, there's for last.
Kate.
And we're gonna do.
I would do 2 minutes and then if they have to, let them go to 3.
2 and then 3. We're gonna do 2 minutes.
If we start running, get it to 3 and then we're done.
All right, it's 9:15. I'm going to open the hearing on Senate Bill 256 relative to the affordability and safety of clinician-administered drugs. And with that, the chair recognizes Senator McHugh.
Good morning again. Thank you, Mr. Chairman.
Welcome
Good
back.
morning, members. Yes, welcome back. And thank you so much for your action on the previous bill so quickly. I am Senator Tim McHugh, representing Senate District 11, the towns of Merrimack, Amherst, Milford, and Wilton. So this bill is not so much housekeeping. It's a little bit more complicated. We had it in the House last year, and it didn't make it all the way through to being enacted. So if it's okay with the chair, what I'd like to do is speak to the general concept that we're dealing with, and then move to an amendment that I've brought that accomplishes what the original bill does, but it's an all after the enacting clause with a slightly more elegant language. So first, I'd like to talk about what the problem is that we're trying to solve and how it benefits patients, makes things safer, and generally improves patient clinical outcomes, because that is the ultimate objective. But really we'll focus on, if we could, focus our discussion on the full replacement amendment that was developed with support of several of the stakeholders, interested parties, and is largely adopted from another state's language that's enacted now. So basically, this bill has been commonly referred to as the white bagging, brown bagging bill. And so what the heck is white bagging and brown bagging? Well, everybody remembers brown bagging your lunch when you were a kid, taking your lunch to school. Well, so that is analogous with this process of having a drug, pharmaceutical preparation of some sort, an infusion drug sent to your house, and then you take it to the infusion center where it's administered, like you brown bag your lunch, you brown bag your drug. So you can already probably start thinking of the potential problems with this, especially if it's a drug that must be critically controlled, time, temperature, chain of custody, all sorts of things. Imagine some elderly patient doesn't even know exactly when UPS or Amazon or Laser Ship, any of these last mile couriers, might be delivering in the middle of July or in the dead of winter some critical pharmaceutical preparation that they need, and having to manage that process when they're critically ill or have some family member manage the process. So therein lies just one of the problems with the brown bagging situation. So by and large, we don't have a ton of that happening in New Hampshire. There are isolated cases where it's necessary because that's the only way to get it to them. So we have a carve out where if the clinician, the provider is involved and the provider deems that that's the only way to make it happen in a rural setting, we can still do that. So there are some cases, but everybody needs to be informed. We don't want the health plan or some arbitrary disconnected pharmacy contractor just to drop a shipment of a critical infusion drug at your house without you knowing it's coming. And that doesn't happen that often, but it can happen. So that's brown bagging. So we'd like to essentially get rid of that entirely without involving the provider, right? Your doctor. We want the doctor and the patient to be making those decisions in general. Now, white bagging. White bagging is another similar situation, but instead of the drug being sent to the house, it's sent to the place of administration, the hospital or the infusion clinic or the doctor's office. And now that seems a whole lot safer because those medical facilities are skilled with handling these pharmaceutical preparations. They know about time, temperature, access control, chain of custody, and that sort of thing. So, seems good. Well, the problem is if you have someone in a critical disease state, let's just take cancer, right, where your red count, white count is constantly changing and the mix is critical and the timing of that delivery is scheduled. Let's just take, say, chemotherapy where you're on a regular schedule, so many weeks, once a week, or whatever that schedule might be determined by your Dartmouth hem-oncologist. You want your drug for your peace of mind. You want to get your therapy on the schedule that's planned so you know that your disease is being appropriately attacked according to these erudite physicians that are going to cure you of this deadly drug. Well, you show up, they draw your labs. They're not exactly what they expected they would be. So now they need to remix the drug, but the drug that was sent by the white bagging process isn't what you need. Now they send you home. So what do they do with this empty chair? Well, they don't have somebody on standby because they don't have their drug. Or maybe they do, and they use the more expensive pharmacy, in-hospital pharmacy. Costs us all more money. Or worse, the chair goes unfilled for the day, but the clinician still needs to be paid for their time. So these are all some of the problems that can happen. The worst part of this is that patient gets sent home without their therapy and they've got to reschedule. That's the real problem here. And that's the real cost, is that worsening outcome. So think of yourself or your loved one who's got a tumor growing inside themselves, and they've made the difficult decision to go for chemotherapy first versus surgery first, right? And this is a common decision that's made. There's good clinical data to support one versus the other, depending on the type of cancer you're attacking. In some cases, the clinical data says, shrink the tumor, attack the tumor, make it more easy to manage. But that's really stressful on the patient to think, I've got this thing growing inside me in my pancreas, in my breast, or wherever it is, and I've got to sit through 6 weeks, 10 weeks, 13 weeks of infusion therapy instead of just getting it cut out of me, right? This is, think about a layperson patient, and you now have to miss a week of therapy or a couple of days of therapy. It's really, really stressful. So those stress hormones and things that are created by that additional stress, they actually feed the tumor, right? They make it worse. So we don't want this kind of delay and the resulting poor outcomes to happen. So and we also really don't want to increase the costs associated with the poor outcomes or the cost associated with having to go to the hospital pharmacy. So we've built in some controls here in this language, in the amended language, I should say, which is adopted from Minnesota. And that was by suggestion by one of the folks behind me here. And I really do appreciate that. We will hear some supportive testimony by several of those folks. So we've allowed the plans to bill at the lower pharmacy benefit rate, even if the infusion gets administered in the hospital. So I recognize that will be taking a small bit of revenue in the small number of cases where all of that whole scenario all happens, that perfect storm happens. Normally, under current practice, that bill would be generated by the hospital under the hospital pharmacy rate. That's generally a higher rate, a bit of a profit center at times. That's generally a higher rate than the pharmacy benefit plan. So I recognize that we are taking some revenue potentially out of the hospital in those small number of cases. But I think it's the right thing to do. I think we should bill as it would have previously been billed under the pharmacy benefit, the more economical rate. I think that's the best thing for consumers. So for patient safety, for clinical outcomes, patient peace of mind, we're putting the provider who knows best in control. We're keeping the patient safe. We're improving outcomes, and we're controlling cost, all wrapped up into one. Who else has done it? U.S. Pharmacopoeia chapter says we should do it this way for chain of custody. Massachusetts has a bill. Texas has a bill. Minnesota has passed it. A number of other states have either done it or are considering it now too. So that's why I think we ought to do it.
Thank
Happy
you
to
very
take
much.
questions.
Are there any questions from the committee? Senator Birdsall.
Thank you, and thank you. You may not be able to answer this, but do we have any data from the other states that have passed it, like Minnesota, on the impact on the premiums?
That's a good question. I haven't seen any significant data. Last year when we looked at it, there was minimal impact, and all the fiscal notes that we saw were either indeterminate or dart throws. It's just not a huge number of folks where it happens, and I do think that NFIB may have some of that data. I believe that individual has some pretty solid experience from Minnesota specifically. It wouldn't surprise me if hospitals or some of the other interested parties have some more specific data too.
Any other questions? Thank you very much.
Thank you, Mr. Chair.
We will see you later.
I will likely pop in on the ambulance bills
All
later.
right. All right. Paula Rogers. Oh, yeah. Good. Thank you very much, Senator. We have a lot of people signed up today. We have a very busy schedule today. So we're going to ask that you limit remarks to 2 minutes, and hopefully we'll get through this testimony and be able to complete our work today. So thank you very much.
Good morning, Mr. Chairman, members of the Health and Human Services Senate Committee. Thank you very much for the opportunity to comment. I listened very carefully to Senator Magoo's comments, and it's very interesting because he sort of captured a lot of what I wanted to say. He gave you a sense of the strain in the system when white bagging doesn't work. Those things happen. Things happen systemically. And he also talked about issues around brown bagging. I think what really sort of strikes me with this is that within the last decade, a lot of infusions have been moving out of the outpatient setting in hospitals and moved into clinics or doctors' offices. And the reason for that is that I think there was an opportunity to address the costs in the hospital setting, so that an infusion in a hospital setting compared to one in an alternative setting is probably in the range of $7,000 higher. And so this is a significant differential. When the issue of white bagging and brown bagging came to the fore in the last decade, the hospitals clearly had reason to be concerned, and they came and talked quite extensively about what they saw as flaws in the system, incidents where the system didn't work properly, incidents where a patient, as described by Senator Magoo, was in an awkward situation of expecting care and suddenly something was disruptive. His bill, quite frankly, provides an opportunity to address that. And I do not have statistics on how frequently that happens, nor do I remember the hospitals actually providing statistics when things went awry. Stepping into the amendment, which I had a copy of from last evening, I looked too at Senator Magoo's efforts to control how the drugs are shipped for white bagging. And so there's a section of the bill that addresses that quite comprehensively. There's also a section of the bill that deals with an appeals process. a consumer should never feel that at some point they are adrift without an opportunity for a change in plans because of the circumstance they're in. And they should be entitled to rapid amount of information quickly and carefully delivered to address their issues. Again, the amended version, which I think you need to review, actually separate from the bill itself, because the bill itself, as introduced, has some confusing language in it. And a lot of work was done by the senator to come up with a statute, and it is Minnesota, as he suggested, which has a comprehensive structure to address the matters at issue brought to the fore by the Hospital Association. And I know the Hospital Association's here this morning. They may have updated information about issues that they found disruptive to their system, and I'm anxious to hear what they have to say about that. I think those of us that are supporting the bill want the bill to go forward. We're willing to certainly engage with the senator and anybody else who has an interest in amending the bill, but I think it's time for the bill to go forward. I remember when this concept first came to the legislative setting, it was all around a pharmacy board issue that had concern with infused drugs, which were sent to a doctor's office, and merely with a clinician there.
Could wrap up the
Okay.
comments. Thank you. I'm sorry. I know I hate to cut people off, but
Okay, well then, why don't I quickly come to an end
Yeah.
and say, what we will do is, we'll talk about that off record.
Sure.
But be aware that it's a long history and it needs to be addressed.
Sure. Are there, and I am very familiar with that history because I was on the board of pharmacy when that came up. And, at the time, the board didn't have the authority to take any action on that they weren't granted that authority by the legislature. So,
And there was a confusion about compounding and.
yes, absolutely.
I remember that.
Senator Avard.
Thank you, and thank you for your testimony. So, is the amendment complete? Do you think it suffices to meet the needs of what we're
I think
trying to do?
Senator Magoo has the amendment, and I don't know whether he's distributed here this morning or not, but I believe he has.
Yeah,
And so that is actually the form of the bill that you should be considering.
thank you.
It's a replacement amendment.
Right.
Thank you. Are there any other questions?
Thank
Seeing
you.
none, thank you very much. And I just wanted to make the announcement, we are on Senate Bill 256. And if you're not here for 256, I'd ask that you wait in the hallway. We can't have people standing. If you are here from 256 and you still are standing, feel free to stand out in the hall. We will call you when your name is called, and we'll come get you. So thank you. I apologize for that. We're in a small room today. Speaking of the Hospital Association, Kathy.
Good morning, Mr. Chairman and members of the committee. For the record, my name is Kathy Bizarro-Thunberg, Executive Vice President, New Hampshire Hospital Association. And I will say on the outset, I have not seen the amendment. I only heard about this late last night. Have not had an opportunity to receive a copy. So my comments really are to educate the committee about our position on brown bagging and white bagging. What I'm handing out is actually our testimony on the original bill, but attached is a document that we actually put together back in 2021 when we presented our position to the Board of Pharmacy, which are patient stories about the negative impact of brown bagging and white bagging on their treatment and on their access to care. So we believe that even though those stories are from 2021, they still exist today. I work with our hospital members, particularly hospital pharmacy directors, on a regular basis, and this is sort of the bane of their existence from pharmacy professionals. When they receive white-bagged medications for patients, they have to manage them, they have to store them, they have to inventory them, even though they're not their own inventory. And it's very costly and concerning, especially when patients turn out they can't use them, either because they arrived late, they didn't arrive in the right location, the patient's condition changed, and therefore the drugs that came could not be used. So then it's up to the hospital or the provider to have to waste them. That's costly as well. A huge cost in the entire system when it really didn't even benefit the patient at all. So from the Hospital Association's position on white bagging and brown bagging, we believe brown bagging should be prohibited. It's definitely something that is not beneficial to anyone in the system. White bagging medications should be prohibited when dosage and or compounding are dependent upon the current patient lab results or clinical presentation at the time of the medication administration. The only time we believe that white bagging could be considered is when quality and safety criteria are met and mutually agreed upon standards are applied, including that it's a joint decision from both the provider and the payer that a white bagging medication is in the best interest of the patient, or if the patient's medication is a limited distribution drug and is only available from certain supply chain channels. So we recognize there could be some very limited circumstances where that exists, but we believe that a wholesale use of white bagging is not appropriate. So regarding the amendment, I would love to be able to see it and hope that the committee would provide us an opportunity of time to be able to address anything that we may see in that language.
Great. Thank you. Are there any questions? Thank you very much.
Thank you.
Tanya Carlton. Oh, you turned it off. There you go.
I turned it off. Good morning, Chairman Rochefort, members of the committee. My name is Tanya Carlton. I've been a practicing pharmacist in New Hampshire across multiple healthcare systems for over 20 years. Currently, I'm the immediate past president of the New Hampshire Society of Health System Pharmacists. NHSHP represents pharmacists and technicians working in organized health systems in New Hampshire to advance the practice of pharmacy and to ensure that New Hampshire is a model of excellence in the health system pharmacy. So as Kathy stated, we have not had an opportunity to review the amendment. The legislation as written, I agree, does not go far enough. It does restrict white bagging, but it does not address white bagging. White bagging is a concern, as Kathy pointed out, related to some of the things that I've seen at my health systems are patients are sent the medication. It's billed to them, right? They bought the medication. I've had patients pass away. You may remember the IVIG shortage another number of years ago, where we had IVIG on the shelf that we couldn't utilize. We can't utilize that for any other patients. We actually have to waste that medication. So we're talking about tens of thousands of dollars of medications, if not more, that we actually have to waste. And that's, that's a waste on our, on the system. Other things, sometimes these medications end up on, there are logistical concerns. White bag medications may end up on a loading dock on a Friday and sit there for the rest of the weekend, once again rendering it unusable. So basically, I do outline in my testimony brown bagging, white bagging, the concerns which have already been relayed. I would say we would love to be able to see the amendment to see if it does go further with the limitations on brown bagging and white bagging to be able to continue quality and safe care for our patients.
Great. Thank
Hi,
you.
Senator Vard.
Questions, Senator?
Thank you, and thank you for your testimony. So basically, we heard that we want to get rid of brown bagging, but in layman terms, how do we fix without looking at the amendment? What is your suggestion?
Without looking, I think not looking at the amendment, I think really what we have seen work in other states, we do have model legislation that the American Society of Health System Pharmacists have put forth related to white bagging and prohibiting white bagging to allow for buy and bill in the space. So allowing for the use of our procured medications. It does sound like this amendment may address that, where it's allowing for the hospital procured medications to be administered to the patients, though at a lower reimbursement rate as what hospitals would normally charge the patients. It may be a step in the right direction, but without actually looking at the amendment, I really can't speak to it.
Good. You did well. Thank you.
Any other questions? So one of the questions that comes up, and I think you brought this up, and it's important to realize that, what's going on now today, you're getting drugs from everywhere, all kinds of, I mean, imagine a CVS, for instance, or a typical, normal, 10 years ago, hospital had one source of drugs, or maybe two, they had a backup, and you knew where that drug was coming from. So in this case, it sounds like it's coming from all over the place, and maybe, I'm sure there's been cases where stuff has arrived and you hadn't been notified, and you're like, what is this for? We didn't order this, what do we do with this? But one of the instances that, I think about, having worked in your field, is that sometimes many times these drugs we're talking about, chemotherapy drugs, they have to be prepared in the hospital very specifically. So you get a vial of powder that the pharmacy then has to turn into a liquid using sodium chloride, sodium bicarbonate, lactic acid ring, or whatever it may be. What happens then if you've got a patient that's been sent this drug for one treatment and there's a mistake? I use sodium chloride instead of sodium bicarbonate to reconstitute this drug, and now you can't use it for that patient because normally you just go to the shelf and grab another box, reconstitute it, and now if that's the only thing you have, I could conceivably think that the patient may go without.
Well, Senator Rochefort, we always want to do what's right for the patient. So I would assume that what we would do is we would replace with our own drug and the hospital would take the loss on that.
But if you had a limited distribution drug,
We couldn't,
with one
exactly.
patient,
You're
an
right.
orphan drug that
If we weren't able to obtain it,
now the patient is without therapy.
correct.
Whereas if you were in charge of procuring that drug, you could take the appropriate measures to ensure that you always had enough inventory, even for contingencies, correct?
Exactly. And what I will say, immense storage, we needed immense storage capacities for these medications at our previous hospital, at the previous hospital that I worked at. We had a whole half a fridge designated to white bagging drugs. We had a whole cabinet designated to white bagging drugs. We don't use the same procurement pathway, right? We had to track these in a paper binder. We don't have the same way of actually documenting on the medical record. So there are huge pieces that we are trying to fix, but in the end, it does put patient safety at risk.
Thank you. Thank you very much. Any other questions? Thank you very much. I'm going to call Representative Julie Miles. And Representative, I need to apologize to you. Normally, as is the case in the Senate, is we give the privilege of having other representatives and senators testify, at the top of the list. I missed it. I didn't read that properly. You'd think as a pharmacist I could read handwriting, but that's my mistake. So I apologize for that, and welcome.
No worries. Thank you very much, Mr. Chairman and members of the committee. My name is Representative Julie Miles, and I will try to be expedient and not redundant. I'm just going to read a very brief testimony for myself. Representative Julie Miles, I represent Hillsborough County 12 district, which is the town of Merrimack. I'm also a registered nurse, actively working for over 25 years now on the front lines of patient care. In my time as a critical care and emergency nurse, I have witnessed firsthand how every minute and every procedural detail can mean the difference between life and death. And that's why I wholeheartedly support and co-sponsor this bill. Let's be candid. When it comes to clinician-administered drugs, our patients deserve nothing less than the safest and most reliable care available. This legislation ensures that plans use the lowest cost method of reimbursement without sacrificing quality. It guarantees coverage for vital drugs when self-administration is not an option, and these medications are administered by trained professionals in the proper clinical settings. After all, we do not want our patients in the business of being delivery couriers for their own life-saving drugs. This is not just a theoretical improvement. In states like Massachusetts, whose provisions in General Laws, Chapter 93H, have already set a high standard for specialty drug safety. And Maine, similar measures have also led to demonstrable enhancements in patient outcomes and cost efficiencies. For instance, the Massachusetts Department of Public Health's 2022 report highlights reduced medication errors and improved clinical outcomes under comparable safety protocols. By aligning our practices with these proven models, we can deliver better care here in New Hampshire as well. It's imperative that we follow these protocols, standards also endorsed by the National Association of Specialty Pharmacy, to maintain the highest level of care. I'd like to share a brief, deeply personal example. Several years ago, a close family member of mine bravely battled breast cancer. During her treatment, she did encounter similar frustrating delays as have been described previously in the testimonies. The logistical challenges included accessing those critical drugs. The added stress of navigating those hurdles compounded hardship, and it was already a challenging time. So I know firsthand, if legislation like this had been in place, it could have streamlined her care and potentially eased her and her family's burden. I share this not to evoke sympathy, but to underline how vital timely, safe, and accessible care is, and to ensure no other family have to face those similar circumstances. By preventing health maintenance organizations from requiring pharmacies to dispense drugs with the expectation that patients transport them, we will remove unnecessary, potentially dangerous barrier to timely care. In the high-stakes environment of emergency and critical care, delays or missteps in medication delivery can have catastrophic consequences. In closing, this bill isn't just about saving money, it is about saving lives. It represents our commitment to quality clinical outcomes, patient safety, and accessible health care for all of New Hampshire residents. I urge you to join me in supporting this legislation so that we can set the standard of safe, effective, and compassionate care in our state. Thank you for your time and consideration.
Thank you very much. And again, I apologize. Hopefully I didn't make you late for another hearing. Are there any other questions? I just have a question about brown bagging. You know, as obviously you're a nurse, and you know, you understand that some of these drugs, the cold chain storage is important. It's critical, actually. In fact, more and more attention has been put on how important keeping these drugs as we take on more biological specialty drugs that are very sensitive to environment. I would imagine that, and maybe you share my agreement or my thoughts, maybe you don't. I guess that's where the question is going to come from. Wouldn't you think that these very narrow storage requirement drugs, it'd be inappropriate to send those to Elm Street in Littleton, where you don't know how they're going to be stored, how they're going to be kept prior to delivery to the hospital?
Yes, I do think that is less than ideal unless there is a circumstance, one that we can't even imagine today. But if those circumstances did exist, I think a simple fix would be if the physician and the patient agreed that that was the only way they could get the drug to wherever they need it to be infused. If they both have that agreement, I think that should be allowed as an exception, again, just for their outcome.
Thank you. And then another question, and maybe I should have asked the pharmacist this, but you know, one of the things that is called out in the proposed amendment, and I understand we're not going to exec this bill for today because we're getting a lot of last minute amendments on this. USP 800 deals with occupational safety of drugs, particularly NIOSH drugs, which are the point of NIOSH drugs is that they try to kill the cancer before they kill you, right? I mean, they're bad
Yes.
things. I would imagine if that arrives at somebody's house and they drop it, the layman does not have the proper equipment,
No,
PPE to contain it.
Biohazard, hazmat, yeah, all sorts of. There are a myriad of problems with the white bagging and the delivery of a drug at a patient's house. You know, they may sit on their porch for an extended period of time. You know, in the rush of getting to the clinic, they may not even remember to put it in their car. They may not understand the refrigeration or temperature requirements for the drug. The shipper could be late. The patient misses their appointment. Patient goes to the appointment. Their labs are off. Now they have a drug. Can't use the drug. They may still be billed for that drug.
Yeah. Yeah. Thank you very much.
Thank
And
you.
again, thank you for coming in. I appreciate the testimony.
Thank you.
Sure I didn't miss any other representatives here that have been, John Reynolds. Good morning.
Squeaky chair. Sorry.
Yeah, well,
apologize.
that one's a little shaky. I was in that one yesterday, and it was a little. People have made comments on that. And I got to experience it firsthand yesterday, so be careful.
I'll take a look at it afterwards. Mr. Chair and members of the committee, thank you for the opportunity to testify today. My name is John Reynolds. I'm the state director for the National Federation of Independent Business in New Hampshire. We represent over 1,700 small businesses across the state in every sector. And generally, our members are very small, with the vast majority having fewer than 50 employees. Healthcare costs are a top issue for small businesses because it's such an important benefit to be able to offer employees. It's important for recruiting. It's important for retention of employees. And about every 4 years for about the last 50 years, NFIB has surveyed our members on their biggest challenges. We put 75 issues in front of them, which is incredible that they even respond to it, given what they're asked to do, but they rank them. And every year since 1986, including in the edition that was published just this past December, healthcare costs or healthcare coverage, the cost of healthcare coverage for employees is the #1 issue. And we see this problem in the small group market in New Hampshire, where, between 2018 and 2013, premiums increased precipitously while enrollment declined dramatically. And that's not a good cycle to be in. So we support Senator McHugh's amendment to SB 56 because we believe it delivers higher value for our members and their employees while guarding against higher costs. And it delivers higher value by eliminating wasteful practices, ensuring more timely and accurate delivery of drugs, and ensuring that patients, the people paying the bills, can get access to these very important medications when they need them. And it guards against higher costs by laying out a process for what's supposed to happen in emergency situations where the drug is administered outside of the normal payment parameters. It also, as other people have noted, goes farther than the original bill to protect patients and deliver value. And then to Senator Birdsell's question earlier about the cost, I was scrambling to try to find the cost estimates from Minnesota, and I couldn't pull it up on my phone. I apologize. But there is a study, an ongoing study by the employee. Sorry, I'll stop after this one.
Yeah, if you can finish your thought.
Yep. It's a series of studies by the Employee Benefit Research Institute looking at the cost of clinician-administered drugs in various settings, and they found that for 72 of the most common clinician-administered drugs, this study was from 2023, the cost is 76% higher in a hospital setting than in an outpatient clinical setting. So with that, happy to answer any questions.
Any questions? Thank you very much. I had a question for Kathy Bizarro Thunberg. I got one more question. Something came up that I wondered if you could come back and just answer a quick question for us. So I know the amendment that we're talking about that I know you haven't seen yet, but I know you will. It deals with what the previous speaker said and what the senator said, similar measures that were passed in Minnesota. Are you familiar with that at all?
I am not.
Okay. All right. That was an easy. You're off the hook. All right. I'm
you.
sure you
I will certainly
read the
research it.
amendment and become familiar with it.
Yes,
All right.
absolutely.
Thank you very much.
Thank you.
Let's see. DJ Betancourt.
Thank you, Mr. Chairman, members of the committee. DJ Betancourt, Commissioner of the New Hampshire Insurance Department, joined here by Dr. Jason Azes, our Director of Data Analytics. Like everybody else, I'm trying to recalibrate my thinking here based off of the amendment. What I would say, though, generally is the department has long had hesitations around legislation that would impede patient or citizen access to lower cost alternatives. If taking a look at the amendment, I think it is clearly an improvement so far as I can tell. I don't know if you'd like us to consider an updated fiscal note based off of the amendment. We can certainly do that. Mr. Chairman, I understand you had mentioned that you're not planning to exec this today. We can get to work on that straight away. The only thing I would note about the amendment, and then I'll transition to focusing in on the brown bagging aspect of this, is that on page 2, starting line 12, paragraph B states that reimbursement, I'll just give everybody a second there. Does everybody see where I'm talking about? So again, that's page 2, starting line 12, paragraph B states that reimbursement to the healthcare provider shall be equal but I think the concern really is with the cost of the drug, not the fee going to the healthcare provider. So there may be some language tweaks that need to be made to ensure that it is properly capturing what I think is Senator Magui's intent there. So as it pertains to brown bagging, a fundamental principle of a free market system is choice. And so again, we are concerned when we see measures that would seek to curtail practices like brown bagging, because we feel it takes away a choice. As specialty drug prices rise, making informed choices becomes critical. And while I appreciate that the intent behind the legislation is to improve patient care, we fear that it has the unintended consequence of potentially disrupting the healthcare system. So we have some deep concerns about curtailing or in any way trying to ban brown bagging, as we feel that it removes an effective option for patients, a cost-effective option for patients. So I'll stop there. The 2 minutes is up. I suspect we can get into some further material here in the question period.
So I would, you made a comment about the fiscal note. I see the first fiscal note was pretty vague. And if there is an update to that, I would certainly be interested in that. The other thing you brought up was choice. What choice do patients have in brown bagging versus getting their?
Section 3 in the amendment, and I think, I'm not sure what section it was in the original legislative language, specifies that unless otherwise requested in writing by the patient or prescriber.
Okay.
So that's a modicum of choice, and I think we used the word impede or impediment or curtailing is another good word that we've used with regard to this. It adds an extra barrier for the patient to have the choice to access a lower cost alternative to in some cases is expensive medical therapies. And having heard previous testimony, we do appreciate the fact that not all pharmacologic therapies are amenable to brown bagging, nor safe or efficacious. But across the continuum of the many pharmacologic therapies, there are safe and cost-effective options that should be to easy avail to the patient or the provider, and I think that's one of our primary concerns.
Great. Thank you. Any other questions? Senator Abard.
Yes, if I can ask just to repeat on line 12, the cost of the drug, not, I forgot what you said. I was trying to write it down.
Yep, it states that the reimbursement to the healthcare provider shall be equal. I think that's the
your
direct
suggestion
verbiage
is?
there. Well, I think the concern, as I've said, is that it really is with the cost of the drug, not the fee going to the healthcare provider. So I think, again, to fully achieve, I think, what is Senator Magui's intent there, we may need to tweak that language. I got this amendment about 10 minutes ago. I can't tell you that I can tell you what that language should be at this very moment, but we could help get that turned around in fairly short order. We'll certainly work with the senator as well.
Great. Thank you very much. Any other questions? Thank you very much.
Thank you, Mr. Chairman. Thank you, members of the committee.
Curtis Berry. Yeah, be careful there. Choose wisely.
Good morning,
All
members of the
all
committee.
all the paramedics left, so.
Good point.
Yeah.
Oh, we got one right here.
Yeah. All right. You're right. My apologies. You're not in uniform, so it threw me off.
Good morning, Mr. Chair, members of the committee. I'm Curtis Barry here on behalf of the Pharmaceutical Care Management Association, which is a national trade association for the PBM industry. At the outset, I wanted to remind the committee the role of the PBM among their many functions is to keep the cost of the prescription drug benefit low for the employers or the sponsors of the plan, whether it be a fully insured plan, a self-insured plan, state government, et cetera. And to that end, I would like to speak, and I signed up opposed to the bill as introduced, and speak to specifically on the bill as introduced, the piece that's line 19 through 21. Specifically, it references provided that, going above, payment occurs consistent with the terms and conditions of similarly situated network participants. We think there's two problems with that. One is it is recognizing a hospital reimbursement. You've heard a number of people speak to that, a hospital reimbursement under the medical plan versus the prescription drug plan. We also think the way this is written is that it undermines the ability for a plan to use a preferred provider network. It kind of gets rid of, we choose this hospital because it with lower reimbursement versus another. That is, I think, fixed in the amendment. But this is important because there are a number of studies, I'm going to provide you with just two, but there are several that demonstrate the egregious cost markup that hospitals provide for infused drugs. There's a Berkeley study that I'll provide you when I'm concluded, a GoodRx study. In addition, this is a printout for state employees from the state employees plan, and at the very end, it talks about specialty medications. Whether they are administered by a healthcare professional, self-injected, or taken by mouth, specialty medications require an enhanced level of service. All specialty medications will be provided by Accreta Health Group, Inc., an Express Scripts specialty pharmacy. That tells me the state employees plan acknowledges the white bagging as we describe it as a cost savings measure based upon what the reimbursement levels are.
Can you leave that with us?
Yeah, I'll
right.
leave. I have one copy of that. I have several copies of the studies, and I'll just, in anticipation of the question, I think the best way I can describe it is PCMA is comfortable with the amendment as presented by Senator McGue.
Good. That was my question.
Any questions from the committee? No.
Thank you.
Thank you very much. And with that, that's the last speaker that is signed up to speak on Senate Bill 256. Is there anyone else that'd like to speak on Senate Bill 256? Like I said, we will not be execing this today. And with that, I'm going to close the hearing.
White bag, it's okay. I haven't. It's out. No, we just the amendment seemed to clean up a lot of them.
Am I next?
I don't know. I don't know if you're next or I'm next. We're on
125?
125.
That's me.
All right.
But you,
Yeah, I'm sorry. I gotta lose weight.
Yep, I'm all set for that. Thank you.
$125.6.
No, let's not.
Go away, go. Feeling like part of you time.
fish, she wants to make it.
Ooh, you make me love you.
Ooh, you got it.
This is the first real exposure I've had to this. You've told me about this.
It's I have a
this,
karaoke microphone and everything.
There we go.
We had a room singing once. It was just he and I, and everybody's waiting. Bright, sunshiny day.
Yeah.
That's what we did, and people were back and forth. The ladies were not.
I'm gonna take the squeaky chip.
Well,
See, because I'm chunky. But the squeaky wheel gets the grease. Oh, this is awful.
terrible. I sat in one of those in finance the other day. I can get up.
So are we going to do 2 minutes again, or?
Well, I'm not going to limit you because you're the prime sponsor. So
All right, but I have somebody sitting next to me, so I can. You
I
can
don't,
limit her.
at this point, we have 2 people signed up to speak, so I think we're fine.
All right, perfect.
I think there are more, Senator.
What's that?
Don't.
I did not. Good morning. I'm going to open the hearing on Senate Bill 125 relative to clinical eligibility criteria for nursing facility and home and community-based care. With that, I recognize the prime sponsor, Senator Abard.
Well, thank you, all of you committee members, for being here and being very interested in this bill. For the record, I'm Senator Kevin Abard, and I am the prime sponsor of this bill. And basically what I'm going to do is just give a summary of it and then hand it over to Caroline Virtue, who's sitting next to me. And she's not in the squeaky chair. Wow, we're going to have to get rid of this thing. So basically, in summary, a summary of this bill basically updates the clinical eligibility criteria for nursing facility and home and community-based care. And it adds mobility to the activities of daily living. It also corrects the federal references for the definition of, quote, skilled professional medical personnel, and it requires information from the applicant's primary care physician to be considered. It also clarifies the medical eligibility determination and its responsibility of skilled professional medical personnel. It also gives the department staff authority to obtain medical information for the eligibility of decision-making in its process. So that's my testimony. And I'm going to turn it over to Caroline.
Thank you, Senator Vard. That was very comprehensive. Very good. My name is Carolyn Virtue, Granite Case Management. I handed up testimony. Do you guys have that? It's actually fact sheets. Did they? Yes. They have it? Yep. Okay. Oh, all right. Looks like that. And I'm not gonna go through it in its entirety, but I am gonna touch on the key points. The first page of the binder is the CMS definition of activities of daily living. They include bathing, showering, dressing, getting in and out of a bed or chair, walking, which is what I added as mobility. I'm not, I would agree to have it changed to walking. Using the toilet, eating. It also says here, and this is very important, if the sample person has difficulty performing an activity by himself and without special equipment because of health problems, the person is deemed to have a limitation. The way the MEAs are being judged after assessment right now, first of all, equipment is often not included, use of equipment in the MEA. For example, people using a shower chair, handheld devices, and a wand in the shower are being deemed independent in bathing. So that metrics is not being met. The other thing it says here is that a proxy, for example, a nurse, always answers questions about the sampled person's health status and functioning for long-term care facilities.
Can I stop you right there? And I apologize. I know that this is a complex issue, and I've got staff here that's working to get data for our hearing report. Can you just give us a short little background of what this, what the eligibility is we're talking about, what program it is?
So we're talking about the Choices for Independence program. MEA, the Medical Eligibility Assessment. So with that Senator, let's just move on to the first green tab. This is page 4, or the first, whatever color tab it is, the first tab, sticking out tab. This is page 4 of an actual MEA. And they assess this person to be independent with everything except for bowel or bladder continence. If you go to the back, the next tab, you will see that this is the nurse's notes, and it says she states she needs more grab bars. She needs more grab bars. She needs more assistance with bathing, and it acknowledges that she has some. She requires assistance with IADLs. They're on a different page in the book that I did not mark. She uses a walker. The other reason I brought this in as an example is it says she lives alone. Between the time of the assessment and when I got the referral, which was several months, she had been moved into a residential care facility. So she was in a residential care facility, and a month after I got her, she was closed on the May assessment. Now, what that means is we appealed. I'm not sure what the status of that appeal is, but the only place for her to go at that point is into a nursing facility. So the closure of this particular participant was transferred to a nursing facility. I'll go to the second example on the MEA. So behind the blue tab, first sticker, which I don't know where it is. It's usually on page 4. Mine is not marked. But you will see that he is marked as requiring very little assistance with his ADLs. If you go to the next tab, where there's the nurse's notes, you will see that he is in an unsafe apartment, and he has the biggest thing here is foul body odor. So anyone who has foul body odor requires assistance with bathing. And this gentleman was not assessed to need assistance with bathing. So Granite Case Management appealed this decision. This patient was not open to receive care during the appeal because the appeal was 3 days late. So we had no care for several months until the appeal. And the Administrative Appeals Unit decision was in favor of this gentleman, your constituent, who needed care. And then if I could just go on to the third example, and I will be brief. So the first thing in here is the letter from the PCP in regard to the participant. If you go to the first tab, you will see this is a 77-year-old female, by the way, who's been on the program for 7 years. I am sorry. To me, that is reckless and dangerous. No 77-year-old is improving. They're just not. I don't see them anyway. So she is assessed to need no ADL assistance in the MEA. However, if you look at the nurse's note, it says she uses a rollator, that's a type of walker, but is barely able to walk. She needs a motorized scooter and a new CM. The old CM was not me. I got her through this assessment. She has spinal stenosis, post-polio syndrome, and irritable bowel syndrome. Then it says she is independent with ADLs. Well, she's not independent with ADLs. She completes her ADLs with adaptive equipment. And according to the CMS definitions of ADLs, that should be counted. So these are the kinds of problems that we are attempting to fix here. The reference for skilled medical personnel is being changed from the reference for training to the reference for definition. I have no problem with them both being in there. I ask for this change because the department refuses to identify by name and licensure the individuals making decisions. As Senator Rochford knows, I can't walk into a pharmacy and get my prescription filled by an anonymous person. I cannot enter a hospital and get my care delivered by anonymous people. Their first name and their licensure category is on their name tag, and that's required by law. There is no reason that this medical decision, these people are reviewing medical documents, and we should, at least the participant, the patient, should know the name and the licensure category of the people making these decisions. Maybe not now, but at least one or more times during the past year, the people making these decisions would not have met the level of skilled professional medical personnel. These are licensed healthcare practitioners.
Thank you.
Or they're supposed to be. And then I would like to add that there's supposed to be parity between nursing facility assessment and their counterparts residing in the community, and the nursing facility tool, the MDS, does measure mobility. So it's an unfair playing field. And the one last thing I would add is that given the time the department has spent on fighting these cases, and we have overturned virtually every single one of these decisions, I am shocked that they are not in support of this bill, because there is real harm coming to real people, and this issue needs to be addressed. And when we sat with the department last March, they said they would work to fix this. They have not. Thank you.
Thank you. And I have another question for you. On the last section there, page 2, line 22 through 25, as I understand that, Roman numeral 5, these cases of denial prior to being, the way that this bill is written, prior to being denied, it would have to go before their primary care physician for agreement on that denial. So there would be another set of eyes on it to ensure that, you know, and I would assume the set of eyes is somebody who sees these people on a regular basis, more regular basis than just recertification to ensure that maybe something wasn't missed.
Thank you, Senator, for the question. You are correct. That would be required from the physician only in cases where there's a negative outcome from the MEA for a second set of eyes for the people, from the people who treat the client. The other thing that should be noted here in the process, to your question, a nurse completes the MEA and then is not further involved in the process. It goes over to BEAS for a decision. So BEAS is making their decision based solely on that document, 3 documents that are in the folder, no face-to-face, and they don't reach out to people like the case managers who they pay to see them
So
in person.
you bring up a good point, which I want to just so I understand this. So the nurse is going out doing the assessment. The assessment comes back to the department. Is it a nurse or a physician that makes the final determination?
Well, that's the $10 million question that I can't get an answer to. So that's why I've changed the skilled medical professional
Okay.
statute to just make it clear. I mean, it's very clear that if you look at the CFR, the federal guidance, that it has to be a medical practitioner. I believe
Okay.
that
and
someone,
that's on page 1, line 27. That's what that 432.2 is.
yes.
Okay. All right.
And I believe behind the very last blue, I have that language for you.
Okay. Thank you very much. Any questions from the committee? Thank you for coming in.
Thank you for having me, Senator.
Cheryl Steinberg.
Thank you, Kevin.
Hello, Chairman, members of the committee.
Good morning.
My name is Cheryl Steinberg. I'm the Director of the Justice and Aging Project at New Hampshire Legal Assistance, where we serve persons 60 years of age and older with a variety of issues, and one being benefits and Medicaid issues. And I'm here today to support the effort that this bill is trying to accomplish by rectifying problems with the Choices for Independence clinical eligibility redetermination process. There are significant problems with it. And in fact, you know, at NHLA, we've experienced a really huge increase in the number of referrals we're receiving from people who have been on the Choices for Independence program for many years. And all this.
A little teeny closer to you.
Oh, sure. I always have these mic issues here. They've been on the program for many years, but all of a sudden I've been found by the department to no longer be eligible. And it's been a bit baffling to us. With a few exceptions, as I said, most of these people have been on the program for many years, and they have conditions that, like, as Carolyn was alluding to, are not conditions that get better. You know, people don't improve. From what we can gather, there's a couple of problems that we really do think are going on in particular, and then other things aren't as clear. But one is that, as Carolyn was saying, these medical eligibility assessments are not being completed properly. So just so you know, for the redetermination process, they have to, the participants need to go through the same process basically that a new applicant has to go through. They have to get reassessed financially and then get this MEA completed. And the nurses that have been going out to doing these MEAs, the state contracts with this company now called Essentra to do these assessments. I think there's a lot of turnover. I don't think there's good education maybe about how they're supposed to do it. And they're doing these assessments and coming back with these decisions that are these results that just make no sense. So as Carolyn was saying, some people that have need assistance with all kinds of things are being shown that they're independent, and it doesn't jive, and it isn't consistent with what the 10 years of past medical assessments have said. So that's one big problem. I think even the form itself is flawed. The way they have it written up, they have something like it only needs help set up only, and that doesn't make any sense. If someone needs help setting up to go to the shower, then that's assistance. It's not, it's not just because someone needs to physically bring them into the shower. So that should count just as much as any other kind of assistance. So I think that isn't being scored properly. And then they also have the question is, what have you been able to do within the last week? Under the clinical eligibility rules, what it says is someone needs to have help with this at least once a month. So you shouldn't be asking people what they did within the last week. I mean, that's limiting it way too much. So even the form is flawed. So there's that. And then there's this issue with medical records. So the department has people sign these releases so they can get the medical records from the primary care provider to review them. Well, we've heard from case managers that a lot of times the providers are saying, we never got any requests from the department for the records. So that's one issue. And then I guess some of the providers just don't, I don't know. I mean, I have to a lot of times request medical records for cases I do, and it's like pulling teeth sometimes to get records from some of these providers. So they just move forward then with no medical records to even support the decision. Or sometimes the records, like I had a case where the medical records they received regarding the person was just about her mammogram results and a bone density test. It had nothing to do with her impairments that were relevant to the CFI, her CFI eligibility. So they look at that and they see a flawed MEA, and it's like, oh, you're no longer eligible. So and there's no other review. And it is a bit of a mystery. It's very opaque, again, like how the department is making these decisions once they get this information. There is a long-term care unit, and they're the ones that do it, but it's unclear who exactly is in the long-term care unit and how these decisions are being made. And it does seem like maybe they have implemented some new screening criteria potentially too, that's caused some of these terminations all of a sudden. So, and I'll give you just one example of a case I've had that was very mind-boggling to me. She's a woman who's 64 with muscular dystrophy, so that's something you get born with. It's a degenerative disease, so you don't get better, you only get worse. She was found disabled by Social Security in 1991, and she'd been receiving CFI since 2011. So she needs a wheelchair for mobility. She can't walk on her own. She needs help with bathing, transferring, eating, and dressing. For some reason, her MEA, the person that did her assessment, said she's independent and all these things. Then they denied her. So so we did get involved. We got some new medical information, and based on what we provided them, they reversed the department did reverse the termination. And as Carolyn was also saying, I mean, every case we've had, I've tried to count it up. We've had at least about 25 cases, or maybe even more these termination cases of late that we've dealt with. Out of that total, 20 of them we've reversed without any hearing. We've just been able to give them the correct information or get the MEA redone so it's correct. And then the department says, oh yeah, you're right, they are eligible. And then the other 4 that we have, or the remaining, are just pending. So we have had not one case that we had to go to a hearing on to get a decision. The department has done it without any hearing. So I know I have heard the department has many times said, well, all these cases have gone to the appeals unit. We've won. Well, I don't think that's the right metric to look at, because those are cases, I guess, where people aren't getting the assistance they need. They don't know how to provide the information that's needed to support their case. I don't know. I should also point out the referrals we're getting are only really coming from primarily 2 case management agencies, and there are 8. I mean, and Carolyn Granite Case Management has basically been doing their own because we were so overwhelmed. So that means there's 5 other case management agencies out there that aren't referring cases to us. And I mean, I guess those are the people that are either not appealing or appealing and losing their cases. I don't know, I don't know for sure. We have asked the department for some information on that, but we don't have it. So I will say, I think it's a big problem. It's something we're very concerned about. I do think it would be helpful to maybe make some tweaks to the current draft of the bill to make it a little more effective. And I know that Carolyn is willing to work on that. And the department has set up a meeting already to try to maybe discuss how we can make some amendments, which I fully support. And so that's what I would just ask, to give a little time to let us work on this a bit so we can make it a really good bill that really accomplishes the goal to address the problem.
Sure.
Yeah.
Thank you. Senator.
Thank you, and thank you for your testimony. So what I'm hearing is there are people falling through the cracks, and during the appeals process, they're not getting services, so they're suffering through this process.
Well, yeah, I would say this. If they appeal, they do get benefits. As long as they appeal within 30 days, their services do continue. Okay, but they have to appeal. Some people, I guess, maybe they don't appeal, and then they're just off the program. But as long as they appeal, they do get services.
Follow up?
Yes.
And so do they know that they have the appeal process?
It does say it in the notice, but as you know, many people just, they don't understand the notices, even though, they're not that easy to understand. And that's another thing we've been trying to work with the department for many years to make the
Final
notices
follow-up,
more
if I may,
understandable.
Mr. Chairman. So what if somebody has early onset dementia and doesn't even know that they have that ability?
Exactly. No, that's a problem. I mean, the case, well, that's actually another issue. The case managers are supposed to get copies of these termination notices, and my understanding is they don't. So that's another problem. I mean, and this was particularly a problem after the public health emergency ended, and there was all these, terminations coming, and so the case managers had no idea that people were getting terminated, and then there was different dates about when the medical assessments were supposed to be done in their system versus the department system. So there was all kinds of confusion. And then the participants themselves, a lot of them, they don't know how to, if they don't have a support system, forget it. They're just really in a bad way. Yeah, I mean, you have to keep in mind, these are people that really, a lot of them really can't navigate things on their own.
Thank you for your testimony.
Yeah.
Got a question for you.
Sure.
So you and obviously you've got experience in this. You said there are significant problems that you're seeing, increasingly significant problems. You also said that the this service, the assessment service, Accentra, is now doing these. Can you make a direct correlation between the increase in problems and when Accentra started doing this?
Well, no, I mean, they've been doing it for a while. It used to be called KeyPro, and Accentra bought out KeyPro. So I don't know how many years, but the state has contracted with them for a while. So I don't know that that's, I mean, maybe it is. Maybe since Accentra took over, I don't know that I can make that direct correlation,
Sure.
but that absolutely could be part of
And
it.
I'm assuming
I
that
mean,
contract is approved by governor and council.
Yeah,
And maybe that would be a stop for you to
Yeah, yeah.
let them know what's going on with our contracted
Right.
businesses.
yeah,
Yes.
yeah.
Any other questions? Thank you very much.
Okay, you're welcome.
That was the last person we had signed up for Senate Bill 125. Anyone? Henry?
We had signed up first, actually, on the list.
Oh, you didn't check off the speaking. I will check that off for you, and I'll let you have the seat.
Thank you. For the record, Henry Lippman, State's Medicaid Director.
Good morning, Melissa Hardy, Division Director for Long-Term Supports and Services at the department.
I guess the department opposes the bill, but the department feels that the process can be better for people. But I think that there's a lot that we can talk about on the bill and the process, but it basically boils down to this, and it's similar to financial eligibility. The department solicits information. The problem that the department has is that if not all the information, if you kind of look at it as a record, right? If the record is incomplete, we can go out and seek that information from various sources. We have the contractor, we have our team, which includes 2 RNs, by the way. The thing that I think ties this bill to 125, 135, which you heard last week, is I think that, in working with the stakeholders, we need to figure a way to work better together to have a complete record. Because when you hear that in 2024, out of 3,600 people that approximately eligible. 108 cases went to the appeals unit. That's not good for anybody. It's not good for the participant. It's not good for the department. It's not good for the patient. We do have processes of trying to help them. We've done probably more than any other state in terms of trying to keep people eligible. You know, there was during the pandemic, there was a 3.5 to 4 year period between people having to do this process. So, you know, it's getting people acclimated to it again. But I think the bottom line is we need to find a way to make the process work so we get a more complete record. We can't go out to each household and, you know, in financial eligibility as an example, we can't go to their bank unless we were given approval to do so. We've done a lot in terms of our systems to protect people, but at the end of the day, if we don't have a complete record, we're kind of in a stuck position. And what Cheryl said is true, is that most of the cases when the record is more completed, you know, of 108 cases in 2024 that went to the appeals unit, more than 70% of them reopened just based on getting more information. So I think that the issue that we have to tackle is how do we, you know, the case managers have that, you know, when they talk about rate parity and the like, you know, there's only so much work that they feel that's in their scope of their current work that we're paying for. I think what I'm trying to do in the work groups that Cheryl referenced is she has to be invited to the group today, and we're including her as well. You know, I think our intent is to find a way to build a better process to try to complete the record. But, you know, the fact is that we don't necessarily agree with all the interpretations that were stated, and I want to go through that. What I want to do is, as I said on 135, is we want to come back with some policy choices to make it work better for everybody, and particularly the people that are there. And I'd like to pass the time, because I know you have other bills behind us, to Melissa to talk about more of the technical part. But you have our commitment to try to make it better. We've done a lot to try to make it better. You know, like, for example, you know, if a case manager wants to have full access to what we see on the New Heights system, the system that we use on our side to look at what's going on, if they get an authorized representation from the participant that they want the case manager involved, they can see all the messages online. That was an investment we made over the course of this past summer to get that in place. There's more room to improve this for sure. But it isn't because the department isn't trying to work hard to get people eligible. And I would say that New Hampshire, in terms of coming out of the public health emergency, did more than any other state that I'm aware of. And in terms of structuring even the unwind from continuous coverage, we provided the most amount of time. We extended our time frames to allow people to provide information. But obviously, you know, there's still room to make an improvement here, and we're here to tell you we're going to try to work with that and bring you back a solution that I think the parties can agree to. That's our commitment to you. And
well, I appreciate that. I will in a minute. Let me just, you know, and I appreciate that. I appreciate what you have to say. I mean, what we're hearing is when people who have been disabled for decades are not getting reapproved. I mean, that you know, we work for the people, and you know, if you can't come up with a solution, we'll make one. There'll be a winner and a loser, and as you know, that's what we're charged to do. So I would strongly encourage you to work with the groups, come up with something, because if you don't, we'll pick it, and you know, you may not like what we do.
And we recognize that. I also would like to say that you know, that you've heard interpretations of the law and the regulation that our legal counsel wouldn't necessarily agree on all their representations, but that's really not the point of why we're here. We're here to make it better, and you know, we do want to work with you in particular as the legislative body to make an improvement here, and I think there's one available to us.
Very good. Senator Ebard.
Thank you. And thank you, Henry, for stepping up to the plate. Can you show me where in this bill that you're having the greatest heartburn?
Let Melissa address that if that's okay.
Sure. So a couple of points about our pain points in some of these bills. I think one that was brought up was the definition of mobility, and I think we can agree that we could come up with a better definition, and how is that weighted in a score to determine eligibility. For example, just because you use a walker or use a wheelchair in the community does not mean you're a nursing home level of care. So I think that it's an operational definition that we need to sort out in that change in the bill.
Yes.
Well, I think she mentioned with mobility, using the word walking is part of that.
Yeah, I think that would be part of the conversation too. People, if you can walk and you can walk with a walker, is that, a higher weighted ADL score than if you can walk, from a chair to a couch, So I think there's those operational pieces that we need to figure out before we can say, how does it weight a score for nursing home level of care?
May I have a follow-up?
Absolutely.
So with the PCP, do you have heartburn with that? Being notified or having a doctor's note saying, look, this person's 77 years old. She can't walk. She's got dementia. She doesn't belong in, I hate it when people fall through the cracks.
Of course.
And I call it the Department of Bureaucracy. And I'm kind of upset because it's happening. And people are suffering in the process. So that's why I get a little animated when it comes to stuff like this. And so, yeah, if you could be a little more specific. So we're talking about mobility. And, if is there a hang up with the doctor having a say in this?
Well, I think what's proposed here is that if the department decides that somebody is not eligible, that a physician would have to agree with that with the determination of no eligibility. So I think there's some unintended consequences. I think, some individuals don't see their doctor regularly. I don't think it needs to become at this level where we need a physician sign off if we can get the medical documentation that Henry's been talking about. When we looked at, our rates of appeals and eligibility, once we get the information, either from a PCP, from a specialty doctor in conjunction with the case management entities, we're able to keep people open because we have the information that we need to make that determination. I think before we jump to the physician needing to be involved, which I think adds some red tape and will add time for eligibility or not, I think we need to improve our process in getting the information that we need to make a determination.
If I could add to that, I think the trouble that we have with that is that ultimately the state has to make the decision. We certainly want the information. That's what I was talking about, completing the record. I think to the extent that we can draw that information into the record, and that, I think when it's pretty obvious, it's pretty obvious. The problem is sometimes it's not obvious because the record's not complete.
Go ahead. So we have issue, I happen to chair the subcommittee on Alzheimer's. And if somebody has early on dementia and they're all by themselves, they have a public guardian, but nobody else to advocate for them. And they don't know enough to, appeal. Now, how is that remedied? How are they fixed?
I think that's why we value our case management entities. I mean, they're the ones that are boots on the ground with the individuals. They're assigned to individuals, and part of that assignment is ensuring that they get the services that they need under CFI. So part of the improvements that we've made in conjunction with the case management agencies is getting information to them. If we know somebody's coming up for an MEA or is coming up for a closure, that information is available to the case management agencies to help the patient either appeal or help through that process. So I think they're a vital piece of this process, and I don't want to underscore their importance here.
And if I may make a statement, Mr. Chairman.
I will let you make a statement.
And I will stop
Only
from
because
there.
you sang earlier.
Thank you. It is the case managements that brought this forward.
Yeah.
And so it is their boots on the ground that are seeing all this stuff. And all I'm hearing still is, we're going to work on it. We're going to work on it. We're going to work on it. And I'm tired of hearing that because I know why you're working on it. People are suffering and falling through the cracks. And it's not me saying it, it's the people that you just referenced, the case managers. And Can you give me a time frame when this is going to be fixed?
My goal is, in terms of bringing a fix to this, is to so it fits with your time frame for legislating. Okay, and you know, I know that you're frustrated. I'm frustrated as too that we still have this issue open, but I think we have done a lot to try to protect people, but we're not. There's more that can be done, and I think it really involves even a stronger role in the case managers providing information and to build that into the process. At the end of the day, you know, there's someone who is, as you described, right, who you know, in the ideal situation, they've made, you know, they have an authorized rep or they have someone who's, but there's some cases they're alone, right? And, you know, we have to make special efforts in those situations. But, you know, I can tell you that the case managers have come to us with problems. Each time they have, we've tried to implement something to make it better. And I think, you know, this bill is trying to another opportunity to try to make it better. You know, as I said, we make sure that if someone appeals, that we keep them open. We give them more time to provide information. We've provided greater transparency in our systems if they get the authorized position from the person. The next step is really we've got to complete the record of what's available clinically, so that when it's in front of the people making the decision, it's obvious. It should be obvious, right, in terms of what's in front of them. And I think that's what we need to tackle together.
So that's a question that I have. Who is making the decision? So Essentra goes out, gathers the information. We're told it should be a skilled, licensed professional. We're told in testimony that we don't know who that is. Who is making those decisions?
So Essentra is our contractor that, as was stated previously, does all of the MEAs, the medical eligibility assessments. Those are nurses. They provide that MEA data to the department. If there is a concern about somebody not meeting medical eligibility, somebody at the Bureau of Adult and Aging Services, who we have 3 staff members in our department, 2 of which are RNs. One is a skilled medical professional under the definition in CMS. So we have 2 people who 2 out of our 3 staff look at any application or MEA that is questionable or maybe denied because we don't have a clinical level of care. After that, if those 2 are in agreement that somebody is not eligible, it then goes to our supervisor of the unit to review. So in essence,
and that is a nurse, the supervisor.
The supervisor is not a nurse, but one of the 2 people prior to the supervisor is an RN.
Okay, and that supervisor, would the supervisor have the definition of a skilled?
Yes.
Okay, all right. And just to underscore, I mean, I don't like being put in a position of refereeing stuff. You know, I know that you're, you know, willing to work on this. I think part of the thing that I've heard over the last 20 minutes is that perhaps Essentra has a role in this as well. I mean, if they're giving you bad data or they're not giving you a complete picture, I mean, that handicaps your skilled people right off the bat if they're not. And I understand they're nurses, but is their questionnaire, is their intake sheet up to date? Are they giving you a descriptor that's effective in making those decisions? So perhaps looping them in on that would be helpful as well.
And the department does meet weekly with Essentra and their leadership on any cases that are questionable or cases that that don't have either proper information or complete information. So we are in weekly contact with them to review some of those cases that are floating as concerns. So
and they're collecting a flat fee for service.
They're
not incentivized anyway.
No, they get a monthly rate. They also do our level of, our pre-admission screen for a nursing facility. So they're a dual role. They complete our MEAs and they also do pass ours for the nursing facility. So they get one flat rate per month to do both of those services.
Senator Birdsall's got a question.
Thank you, and thank you for taking my question. So if you meet with Essentra, on a weekly basis. Do you ever review with them the ones that are overturned and where they might have missed the issues?
Yes, and I don't want to turn this into winning and losing in appeals, because I think our definitions of that are pretty different. Out of the number of appeals that have gone in front of the Administrative Appeals Unit, one has been upheld as to not meeting our standards and was overturned as far as keeping services on. In the interim, during that appeal process, as some of the other folks have stated, we get additional medical information that allows us to keep somebody open. And so, again, I don't want to make it into a winning and losing appeals, but as Henry and I have stated, if we get the information that we need clinically, either from the physician, from the case manager, from a specialist, we're able to keep people open if we're able to make that determination.
Yes.
So does the additional information you get, does that go to a Centra?
No, that goes right to the department.
Okay, thank you.
Senator Ebert.
I think Senator Prentice.
Oh, Senator Prentice.
May I just, thank you, and I just want to do a quick follow-up on Senator Birdsall's question. So with the, I think this sort of requires some research on our part, but within the contract with the Centra, is there a performance improvement or a quality control provision? And how is, I think knowing how that's executed might help us get to some of this.
I can provide you with that information, yes.
Thank you.
I do have a question.
Senator Avard.
So a number of 130 cases seems to have been brought up. You said one was overturned. I'm wondering, does Centra actually, do they talk to the case managers?
Does a Centra talk to the case managers? I don't know that. I know that they can see what's in the system, what a Centra has done as far as scheduling for MEAs, and they can see the MEA in the system. I believe they do communicate with each other because of the scheduling of the MEAs. Sometimes the case managers want to be there when a Centra nurses go out and do assessments. So there is that communication between a Centra, assessors, and the case management agencies.
Great, thank you. Any further questions? We'll let you out of the hot seat. Thank you very much for coming in. The next person on the list, Rosalie Yarnow. Oh, we're gonna get to these people first. No.
Good morning.
Excuse me, you want to speak with? No. Okay. We'll get you an opportunity at the end. Yes. We got two more here. All right. I'm sorry, Rosalie.
Hi, good morning. Thank you for letting me speak on behalf of SB 125. I am a CFI case manager for Granite Case Management, and I am very much in support of this bill. Being a person who is in the homes of the patients that are serviced by the CFI program, I have seen like what Senator Evard had mentioned, a lot of people fall through the cracks. People who have diagnoses that don't improve, and because they're able to complete many of their ADLs, they're removed from the program, but yet those diagnoses, things like dementia, make it difficult for them to appeal without assistance. And the other thing that hasn't been brought to light yet is that many of the patients in the CFI program, they qualify medically, but they also have to qualify financially. And to qualify financially, their income level is very low. And so they don't have the ability to replace services when services are removed. And so they're very, very vulnerable people. And I'm just speaking about this because it supports basically the amendment where it shows that they're very vulnerable. It shows that they are in need of these services. And so a lot of the patients need services, for instance, a emergency Pierce device. That's to detect falls. And so there's the amendment about the mobility. And when a patient falls through the cracks because they find, they don't qualify medically, they're deemed to not qualify medically, something like an emergency device is turned off automatically. A lot of these patients who financially are at the lower income rely very heavily on nutrition programs. And CFI has authorizations for nutrition programs and home delivered meals. And when they fall through the cracks, those are immediately turned off. So somebody who heavily relies upon those meal deliveries all of a sudden has a huge gap in their ability to eat properly. The mobility issue, like I said before, if their emergency device is turned off because it's no longer being supported by CFI payment, then now they're at a fall risk. And so when they rely heavily upon these CFI services, like I had mentioned, they can't just go out and pay for somebody to come in and replace them for the help that they get, for people coming in and having eyes on them on a regular basis. And so people that go from having all these supports to immediately having no supports at all. And if they are a fall risk, then they end up, being in danger of things like falling. And people can, without those daily visits or weekly visits from CFI providers, the worst case scenarios can happen. They can fall and be in their home and nobody knows. A lot of the times my CFI clients don't have support from the outside at all. So they have no family, they have no friends, they have no neighbors involved, and they rely very, very heavily upon these services to keep them safe in their home. And for those services to be shut off immediately is a massive detriment to these people. And so I know that when somebody comes up for their MEA assessment, they are reviewed, and then the department has the final say. And my experience has been that they at times will state that they are requesting records from a doctor. And like the previous people that were speaking, sometimes those doctors don't send or don't fully understand what's being requested of them. So they'll send out insufficient information, incomplete information. And then the determination is made and the person loses services because the doctor didn't fully understand. And so one of my questions or points that I'd like to bring up is that everybody says that they're working on it. And yet, there have been some small changes that have helped support, gathering of that information. And if a client appeals in under 30 days, then the authorization for CFI stays in place and their support stays in place. But again, if they're not supported by friends or family, or if the CFI case manager is not alerted to the situation at hand, then there's no knowledge that it's even taking place. Do you have a question? Sorry.
I do. Does that
Yes,
written all
sir.
over my face?
Yeah.
But it's up to the chair.
Yeah. Are you
Yes,
ready
sir.
for a question?
I could, yes.
Absolutely.
So, have you been in contact with Accenture at any point, or have they asked their CFI and caseworkers like yourself if this person is eligible or ineligible, or what's the status?
Well,
How often does that happen?
We don't speak of eligibility because they're an independent assessor. So they come into a home and they independently assess them according to the paperwork that they're given to do that assessment. But to answer your question, if everything is going according to plan perfectly, then we are given knowledge of a date for the MEA assessment. And if we so choose to, if we feel that a client is at risk, we attend that MEA. But we can't tell those assessors what to put in the MEA or not. They ask the client questions, and then we can cite basically our case notes and what we have seen over the course of the year as far as that person's ability to say mobility or their ADLs or IADLs, their diagnoses, we can confirm what we might have. But sorry, go ahead.
Am I that bad?
You don't play poker.
No.
Don't.
It's okay.
So, have you ever had recommendations looked at and ignored?
Well, I'll give you an example. I had been present for an MEA where they had gone over their questionnaire and they had cited that the person was not requiring assistance with any ADLs, even though I had said that person relies heavily upon their phone alarm to administer their medications and to be able to take their blood sugar levels because they had to do that 4 times a day. Without that phone reminder, they are not able to remember and they will consistently miss it along with their mental health medications. And then I had the question about the ADLs. That person was not able to physically bathe himself. He had previously had a stroke. He was not able to fully bathe himself. And yet none of those ADLs have been checked off because after the MEA is complete, we can see it once it's posted by the Department of Health and Human Services. So for us to see, but yet at the bottom where the nurse puts in the note, they cited that the person was unkept. Their clothes were not buttoned up properly. They were not wearing socks. They were not, they smelled bad. They were not bathing. So the contradictory information in those MEAs is definitely a concern.
Any other questions? Thank you for coming in today.
Okay. Could I just put one more thing that's so important?
Yes.
Okay. So we're in a denial of services by the department, and there is an appeal process, and that appeal process heavily relies upon gathering of other information that medically supports that the participant needs CFI services. This amendment where it specifically speaks to the client not being removed from CFI services without the agreement of their doctor, I don't understand why the department, if they're getting insufficient information or incomplete information, why the department cannot simply have a questionnaire for a doctor so that they understand the gravity of what's being asked of them. It would be a simple piece of paper with the appropriate questions asked of a physician to support whether that patient should have assistance with ADLs or IADLs. And so I don't understand why that's difficult. So sending out a vague request to a doctor's office, I've had many doctor's offices that have said, again, we didn't get it, or we didn't know its importance, or we don't have, or they'll even cite things like we don't have permission from the patient to send out this information. But we also, as CFI case managers, when I just want to say a couple of things, and I'll be very quick. So other than the form, when there is when somebody is being questioned and we see a bridge authorization being placed for a patient that's awaiting the MEA, because regularly the MEAs are very late, or they're awaiting information from some other source. The only thing I have been able to see as a CFI case manager, when I directly correspond and I directly ask, what is the holdup? Why is this person not being approved? Because I can either see, that I can see that the bridge authorization is there. The only answer I get back is awaiting MEA. And if it continues and I can see the MEA plainly that it's been completed, or I'm in conversations with a Centra who does the MEAs and they say, no, we did it, we submitted it 2 months ago or a month ago to the department, then I will send out a correspondence specifically asking, you know, is there a holdup? Is there anything that we can do to help as CFI case managers? And all I get is under advisement. So there's not clear communication. And so I just want to testify to that.
Thank you very much.
Thank you for your time.
Thank you for coming in. Yes. So Janine McGarvey. Welcome.
Thank you for having me. I just want to say this is my first time here, so if I'm not following protocol, I apologize in advance.
You're all set.
Thank
You're good
you.
to go here.
I'm kidding.
My name is Janine McGarvey. I am a registered nurse, have been a registered nurse for 23 years. I'm dating myself. The majority of it has all been in home care, both in skilled care and a nurse, healing wounds, so on and so forth. And now for the past 3 years in unskilled care. I am the administrator and director of operations for Eminence Home Care. So we are actually provide the caregivers in the homes. So we kind of are looking at it, I guess, through a little bit of a different lens. I will say that I 100% support this bill, both from a home care perspective, but also as a nurse. As a nurse, my responsibility is always going to be the patient first and foremost. I would like to say that defining skilled professional is extremely important. And the reason I say this is because in my experience in home care, you have a nurse come in and it takes weeks to train them specifically how to care for a client in the home, particularly how to perform assessments. For instance, I heard somebody talk about the ADLs, meaning activities of daily living, and that includes dressing, bathing, the ability to transfer from one position to another, or one surface to another. This, talking about walking, we walk on several different surfaces, and it requires that we assess that as well. Walking is not just in their apartment from the couch to the chair, as somebody else suggested. It is also stepping into the shower. It is walking on carpets that maybe your feet can grab, walking on gravel coming in and out of the home, walking on snow and ice. For somebody to be independent, they have to be able to do all of those things without any human assistance. I mean, let's face it, I felt like I needed help this morning walking down the sidewalk. So that being said, I think to take somebody that is a non-skilled professional, such as, somebody who's not an occupational therapist and had years of training in this area, and maybe somebody who's worked in a doctor's office but doesn't have that same level of intense understanding, is really doing a disservice to our clients. They're ending up in the hospital. They're ending up placed in nursing homes. They thrive in their homes. That's where they want to be. They deserve for us to help keep them there safely. So that's another component of these ADLs, is just because somebody is doing it does not mean they're doing it safely. I will give you a quick demonstration. Somebody says they are able to put on their footwear. They're able to demonstrate doing that. As a nurse, my response is, show me how you do that. Sidebar, these assessments through Essentra are all interview. Are you able to get yourself dressed? Can you walk without help? They say yes. That client doesn't know what it looks like to truly answer that question. Are you able to, they're just saying, are you able to walk? Not, can you walk on gravel? Can you walk on ice? Can you step into the shower? And then can you show me how to do it? I can't tell you how many times I've asked somebody to show me how they took their shoes on and off, and they, from a seated position, bend over, and that's a tumble out of the chair. Or it's at least at risk of that. That is not the proper way to do it, but they will tell you they're able to do it. But it's very risky. The proper way would be to put your foot up here and do it that way. So it's scary. the amount of people that are at risk, and a lot are being missed on these MEAs. And when we have professionals who are performing these assessments that don't really have the qualifications to do so, we are not giving it our best. And that's not okay. One more thing that I just wanted to say, and that is that in 2022, my mom was a recipient of CFI. The nurse came in to do the MEA. I was present, and 15 minutes she was in and out. Interview. If I was not there, my mom wouldn't have gotten the services that she got. Fortunately, she had me to be there. Lots of other people don't. And maybe they have somebody to be there, but they don't have somebody with the knowledge that I fortunately had from my mom. Thank you.
Thank you. Any questions? Thank you for coming in. See, it wasn't so bad.
Not at all.
No.
I might be back.
We're here every day. Sir, did you want to speak?
Yes, if I can.
Absolutely. Come on in.
You don't want the squeaky chair.
If you could state your name for the record.
Yes, Kerry Firmer. I'm the administrator for Granite Case Management. Just a couple of things and maybe add some clarity. First of all, the case management agencies meet monthly with the department. We're here today because we're not getting resolution. And the reason we come back to legislative relief is because we're trying to get accountability into the system. That's the ask. It's not that Henry Lippman's a wonderful guy. So is Melissa. So is a lot of people on that staff. But when you go month after month after month, the case management agencies and the case managers are the front line. They're in the home. They see what goes on. Often the response is this whole business about whether it's the rate structure or MEAs, a lot of this is outside of the direct purview of the case management agency. And yet we're there. Why? Because we don't want to see people fall through the cracks, frankly. So I need to add some clarity, all right? I want to be crystal clear. This is not about doing the finger pointing. This is about looking to how to improve process, not make it personal, and find a solution for everybody. This problem is not about 104 appeals, although it is about 104 appeals. If you're in the appeals bucket, you're at the end of the pipe. You're sitting there with no services, no fast remedy, 30 days of bureaucratic churn, and you're waiting to get it to be heard. And even accommodating that is a paper process to the very same people that couldn't complete the beginning of the process in paper form. So it's not just about the 104 appeals. I can tell you broadly right now, and this is not complete speculation at all, but based on the derivative. For our agency, over 25% of our cases right now are being bridged. Here's what's worse. Well-intended as it may have been, Henry and others in the department last year put in some remedies in the New Heights database system. This is auto-triggering bridges. We have people that are slated to close. We have 25 on a short list right now, slated to close in the next 30 days. Probably will close before that because the bridge date that you see in the system is the last date. It's not necessarily the first date. So if you extrapolate not just Granite Case Management, but I can assure you the other agencies, I won't speak for them, but if you're looking at a rough number of 25%, you're talking 1,000 people, round numbers, right? 4,000 people in the total pop. It's a little less than that. But if you want to round the numbers, we're talking 1,000 participants at risk in a home environment and across the spectrum. So that's why we're seeking language relief, because we've been meeting for months. Some of you hit the nail on the head talking about the contractor, Accenture. Accenture bought out Kepro. Our local contact is in Florida. Okay, and so we've been asking folks at the department, you need to put somebody on that. And I'm great. Melissa stood here today, and God bless her. They meet monthly. Well, are we asking the right questions? And the other question ought to be asked is, why isn't case management sitting there? Because we would love to be there, not because we love meetings, but to make sure that the outcomes are being attained, not just proliferated down the runway or kicking the can further down the calendar. So I wanted to add that clarity. This is not about the 104, although it is. It's about the broader medically bridged patients in the database right now. And you see that. You see that in the handout that Carolyn provided earlier. So I would ask you, that's what an MEA looks like. And the last thing I'll say is, Rosalie touched on it. She's one of our case managers, and we're happy to have her. But this is often reported, less than 15 minutes of an assessment. I can't answer. I don't negotiate those contracts. The state does. But help me understand, you go in, you've never seen a person, and in 15 minutes or less, and I'm not saying in all cases, but in a lot of cases, a considerable amount, I'd wager to bet it's probably 30 to 40, maybe even upwards of 50%. We're assessing a person for a whole year in less than 15 minutes. And then using that document, in many cases, frankly, against them, because it was improperly drafted and the wrong results were concluded. So I wanted to add those, Senator. I appreciate you allowing me 2 minutes at the end of your hearing. I know it's a long day, but I think it's really important that we don't convolute the issues here. This is more than 104 appeals. The reason we're here is we're trying to seek relief through your committee and the legislative process so that we beef up accountability and get it done.
Thank you very much. Any questions?
Thank you.
No, thank you for coming in.
Thank
All
you,
right.
Senator.
Is there anyone else that would like to speak on Senate Bill 125? With that, I'm going to close the hearing. We will not exec this bill today. I think there's a lot of work that needs to be done. We're going to close the hearing.
I just think some people are suffering. No offense to Henry, but I just think I'm next. The bureaucratic churn, what a phrase. Highly sensitive to institutionalization.
Yes. We're good. 2 minutes. Yeah, we're going to do 2 minutes.
2 minutes, okay.
Yeah. What's that? We're gonna start with this one.
Are we ready?
No, my bill. I gotta get my, what are we at? 131.
131 FNA. We're going to open up the hearing to 131 FNA, and we're going to hear from Senator Rochefort.
Good morning. Thank you, committee. For the record, my name is David Rochefort. I represent Senate District 1. In an effort to save on time, I'm just going to tell you it's the top 2,500 square miles of the state of New Hampshire. Before you, you have Senate Bill 131, and this is relative to long care eligibility and making an appropriation therefore. I was asked to put this bill in, but when I was asked to put this bill in, I said, definitely, I want to be a part of this. With a big district becomes many things. And one of the things that I have in my district is a lot of nursing homes. And I've been told I have more nursing homes in my district than any other district. I haven't validated that, but I have a lot of them. And as I work in my community and travel in my district, one of the things that's consistent with the nursing homes is the long delays for approval of Medicaid applications for the residents. So you go into a nursing home oftentimes and you wait to get approved under Medicaid. And most times that comes, but and they'll accept, these facilities will accept patients even prior to approval of Medicaid when the applications have been submitted. But while they wait, the nursing home facilities receive little to no payments for these folks from Medicaid. And in fact, the nursing facility, as I understand it, nursing home facility is on the hook for this period of time. And asking anybody to subsidize the state is a challenge, but in this case, you have these nursing home facilities that are, in my opinion, subsidizing the state. And there's a process, and I don't use that in a degrading way. But the reality is, they're providing service, they're providing care, while the applications work through the process to get approved. In these times, these facilities absorb the costs, and this can go on for months. And in times, I've even heard of a year this goes on while they're taking care of these patients. And I want to point out, the patients are getting care; they're getting excellent care. But it comes at a cost to the facilities. This situation is unfair to many of these facilities, most of which are barely able to survive. And I want to highlight that. We've got a number of facilities that are just hanging on. And you think about that, what they're doing, they're taking care of, we've talked a lot about the age, we just got off of a hearing about people that need extra help. These are the elderly of our community. And if they're not there, they're not able to make it, who's going to take care of them? And so if unaddressed, the situation will result in the facilities being unable to take care of the other needs of keeping their facilities open. Okay, making sure the roof is fixed, making sure the driveways are plowed, making sure the heat and the air conditioning work because their resources are going other places. And then, of course, the biggest risk is risk of these facilities closing. Senate Bill 131 seeks to solve this problem by creating provisional eligibility for applicants whose Medicaid applications have been pending for 90 days. So this goes after, it's not everyone that this goes, this addresses, but it's if something's taken a little bit longer, if they're going past a month or two, that's where this provisional eligibility will kick in. And I don't have the numbers, probably somebody does, about what percentage of that goes on, but what that sort of effect. But this isn't for, the nursing homes are not asking to take everyone. We're just talking about the 90 days after. Once the Medicaid application is later granted or denied, the facility shall either repay the state. Once they're starting to get those payments, they'll actually repay the state what they received during that provisional eligibility time, if there's any difference in that. Provisional eligibility will automatically terminate 18 months from the application date unless there's a final determination on the Medicaid application before that. This bill would drastically reduce the financial pressures on New Hampshire nursing facilities that are coming from these long delays in approval. And finally, one more thing is provisional eligibility would serve as a type of bridge financing. And that's really what it is. We're not asking for, a blank check. We're asking for a bridge during these times that'll enable our facilities to better manage their finances during this Medicaid application process. And then finally, I don't know if we've received a fiscal note yet. Have we received a fiscal note yet? I probably am not in a position to ask questions, but I don't believe we have. But last I checked, we had not received a fiscal note on this bill. But I ask really not to focus on the fiscal note. I understand when I put this bill in, I know I needed to ask for some type of money. I chose $1.5 million just as I threw a dart. And I talked to a number of the facilities. We weren't sure on what that right number would be. But the important thing really is the policy. And that's the important thing as we come out of this today is, and I'm not going to, the folks from the nursing home communities, they're not fooling themselves. They understand the situation we're in the state, but we really want to work on the policy of this, and we'll work with finance after we get it out of this committee, if the committee so chooses. So with that, I'd be happy to take questions, but I know there are people behind me that can probably give you much better answers than I can.
Thank you, Senator. Are there questions? I saw your hand first, so go ahead. All right. You get mad at me.
Thank you, Senator Rochefort, for taking my question. So will the provisional eligibility assist with what we heard about last week and what we know is happening with patients that are in hospitals that need to move into, into nursing homes is one of the potential, like we have this holdup of folks that are sitting there that we just are working to discharge, and the eligibility for this type of eligibility was discussed almost 2 years ago as being one of the potential solutions to get that done. So we knew where, if we could move them and they would be covered temporarily.
Yes. Yes. And I think the answer to your question is yes. The details, the folks would be able to expound on the details of that. But yeah, that's a big concern. I mean, that, having come from the House, we're on the county delegation, and you are in charge of your, as you know, the Grafton County. Those are some of the issues that I know we're faced with there, and the effort is to help ease that.
This might serve as a bridge to move us further, to start moving people where they need to be.
Yes.
Okay, thank you very much.
And this might be an answer that someone behind you, when the nursing homes are paying, will they get back pay for the expenses that they incurred while they were taking care of the patient in the nursing home?
I'm going to have somebody behind me explain the finer details of that. Yes.
Thank you.
Any further questions? Seeing none, thank you, Senator.
Thank you.
Senator Abbas is here. What's that? Senator Abbas is here. He's on the list.
Oh, for this?
Yeah.
Oh,
He
all
wants
right.
to speak.
So do you want me to take over here?
Oh, no, Senator Abbas?
Can I take over?
Of course you can.
All right.
Good morning. Good morning, members of the committee. I'm Senator Darrell Abbas. I represent District 22. I'm here to testify in support of Senate Bill 131. I want to thank my friend from District 1 for putting this in. I didn't hear your testimony because it was standing room only.
It was
so
awesome.
Yeah.
You didn't hear the applause?
Well, you looked great from the window, so I'll give you that. But in speaking with a nursing facility in my district, this bill is really essential to their long-term viability. When it comes to the Medicaid reimbursements, they're going 6-9 months waiting. They're floating that. It creates serious cash flow issues. It requires them to make some really difficult decisions, and the long-term viability, would be in jeopardy without this passing. So, I think on average they have about 92 residents in the facility. 40 of them, I believe, are on average on Medicaid, and they have about about $700,000 and waiting for reimbursements. And for a nonprofit to go through that, again, the long-term viability is questionable. For an organization that's provided care, in Southern New Hampshire for as long as they have, I think this is critical to allow them to maintain that. So I hope the members of the committee support this and not to pass. Thank you.
Thank you. Any questions? All set. Awesome testimony.
It was really good.
We're on a roll here.
Didn't look as good.
Yeah. Brendan Williams. Yeah. So Brendan, in an effort to stay on or get back on track on time, we're going to limit testimony to 2 minutes. So I hate to do that, but that's where we're at today.
Of course, Mr. Chairman, thank you, and thank you, members of the committee, and thank you, Mr. Chairman, for sponsoring this bill. And I can do math. This bill's about math. The majority of the committee is sponsoring this bill, so I thank you for that. I'm not going to belabor the bill. I think as you summarized it, it was perfect. I've given you some examples of facilities in the districts that you represent in terms of the amount of money that they're waiting for unapproved Medicaid applications. And when you look at a facility like the Lafayette Center in Franconia, which only has 72 beds, and consider the fact that they're waiting for over $500,000 in payments, I think you can get a sense of the burden that imposes on your ability to pay vendors, on your ability to recruit and retain staff. We're not looking for a handout here. We're looking to get paid for the care that is being provided. And this provisional payment idea has been employed in some other states. There would be a revolving fund set up. Yes, it's going to be an amount of money that's relatively large, certainly larger than $1.5 million. But money will go in and money will come out. This is a revolving fund. It's sort of a bridge loan system. The state ultimately is not going to be out money where applications are not approved. In response to Senator Birdsell's question, yes, a facility is made whole if a Medicaid application is approved, but that can take some time. And we're not here to throw the department under the bus or the family members who sometimes can be a little difficult to deal with in terms of getting the paperwork in. It's a complicated process qualifying for Medicaid, and there could be one piece of paper that's the hangup. We're just here about a solution, and we think that this is a positive. Senator Prentice had stepped out, but we also think this helps the system as a whole. Hospitals, so that they're not jammed up. There are hospitals that are actually paying nursing homes in order to take those whose Medicaid applications have not yet been approved. So this would help the whole system, and we commend this bill to your attention, and I'd be happy to take any questions.
Are there any questions? No, thank you very much.
Thank you, Mr. Chairman.
Kathy Pizarro Thunberg. It's just like the old days, Kathy.
No. Good morning. For the record, Kathy Pizarro Thunberg, New Hampshire Hospital Association, representing all 26 of our state's community hospitals as well as specialty hospitals. The Hospital Association is in support of Senate Bill 131 relative to the long-term care eligibility and making the appropriation. This bill is one part of a broader three-legged effort to lower complex barriers to patient transfers out of hospital inpatient beds and into a more appropriate level of care. I want to thank all the stakeholders that spent many hours committed to this important concept of making sure that we can knit together what the appropriate solutions are to support these patients. I'm here on behalf of Ben Bradley. He presented a barriers to discharge report last week, I believe, at a prior hearing that really illustrated what we were seeing from a hospital's perspective of patients getting stuck in a hospital bed waiting for a long-term care bed, particularly because of Medicaid not being paid. Certainly in a hospital bed, these patients are being safe, but they're no longer medically necessary to be in a hospital. So they really should be in a lower level of care, such as long-term care. So we just wanted to make sure that we iterated that from the hospital's perspective, this is a great partnership to ensure that our long-term care facilities receive the reimbursement that they need for these patients and the patients receive the care that they should at the right level of care. So happy to answer any questions.
Are there any questions? No, thank you.
All right, thank you.
Kate Horgan.
Thank you, Mr. Chair, members of the committee. My name is Kate Horgan. I'm here on behalf of the New Hampshire Association of Counties. In this case in particular, your 11 county nursing homes, 3 of which are in Senator Rochford's district. The association is in support of this bill. We are very happy to see this move forward. As I think almost everyone on this committee has been a county delegate at some point in their career. So we appreciate that Senator Rochford provided some flexibility. This program is not mandatory. As you know, nursing home administrators in the counties are not the only ones making decisions. We have to answer to both the commissioners and the delegation. So we appreciate that. And we also very much appreciate the last line that says that the counties will not be responsible for paying for this. As you all know, the county cap, counties are responsible for 100% of the non-federal share. So we certainly appreciate that inclusion, and I'm happy to take any questions.
Are there any questions? No, thank you very much.
Thank you.
Charles Powell.
Good morning, Mr. Chair, members of the committee. Thank you for allowing me to speak. I will be brief. My name is Charles Powell, as you know, and I'm here on behalf of the New Hampshire Healthcare Association and its many members. I am the primary drafter of SB 131.
Nice to meet you.
It's nice to meet you too, sir. at least with regard to the procedural aspects of the bill. It's a bill that we've worked very hard on in cooperation with the Department of Health and Human Services, and I wanted to express how much we appreciate their cooperation in working on this bill over the past many months. The prior testimony here today is well taken. I think the problem that the facilities are facing has been well outlined. I would say that it is an existential problem for many, if not all, facilities at this point in time. We believe that SB 131 has great potential to alleviate the burden that facilities are experiencing, have been experiencing for some time. It is a simple, uncomplicated bill, in my view. Under SB 131, after an application has been pending for 90 days, the department will grant provisional eligibility for a Medicaid applicant to a facility that requests it. In addition, at the 12-month mark from the filing of the Medicaid application, if no approval for Medicaid has been obtained, then the facility must then file a petition for appointment of a special Medicaid representative in order for provisional eligibility to continue after that 12-month point. For those not familiar with special Medicaid representatives, that is a professional that's authorized by law pursuant to NHRSA 151I2 to collect and complete Medicaid applications. The requirement is intended to ensure that the application is completed and prosecuted to conclusion, and all the informational needs of the department are quickly satisfied. I recognize that my time is up, but if I could please continue, I do think that I have some important points for the committee to hear.
Well, if you could make it.
I'll make it very quick.
Thank
So,
you.
The requirement of a special Medicaid representative is there so that provisional eligibility is only in place for as long as is absolutely necessary. Now, the provisional eligibility can continue for 18 months unless it is otherwise terminated, and there are some provisions in the bill with regard to the otherwise terminated language. We need to make an amendment or two to that. In discussions with the department, they've requested a couple of changes we consider to be nothing more than housekeeping issues, and so I don't perceive that to be a problem. But this brings me to the most important aspect, I think, for the committee to consider in my opinion, in terms of fiscal responsibility. This is not a bill that requires an unreimbursable expenditure or what I would call a wasting fund. Instead, it is a revolving fund that will be replenished for facilities who request and participate in provisional eligibility. This is so because where a Medicaid application is later approved, the facility has to pay the money back to the fund. And even if it is denied, again, the facility has to pay the money back. So the fund remains ad infinitum to the extent that the bill remains in effect. Thank you. I'd be happy
Very
to
good.
take any questions.
Are there any questions? No, thank you very much.
Okay.
Is this Chuck Crush? All right. Welcome.
Thank you. Good morning, everyone. My name is Chuck Crush, and I'm the CEO and administrator of Salem Haven Nursing and Rehab in Salem, New Hampshire. Mr. Chairman and committee members, I'd like to thank you for the opportunity to address you for the next few minutes. We're one of the few independent non-for-profit nursing homes in New Hampshire. We're operated by an all-volunteer board of directors whose mission is to serve the elder citizens of Salem and surrounding communities. We serve both needs as a short-term rehab and as a long-term care facility. We currently have 92 residents and employ 146 people who make sure we achieve our mission of excellent care each and every day. We have 40 residents who are currently receiving Medicaid, which pays us about $255 per day for nursing care, food, activities, and some medical supplies. The local hotel charges $317 a night for a room. The reason I'm here today is we have 13 residents who are pending Medicaid. Some of these residents have been with us for almost a year with no confirmed payer source, and we continue to provide the needed care that they require and deserve. Typically, when someone applies for Medicaid, the process should take about 90 days. We have residents and families who will submit documents, and as they're being processed, they're out of date due to the delay. I would like to point out that I think the department, DHHS, is doing their best with the resources allocated to them. We do have a monthly call with them for 30 minutes to review the pending Medicaids, and we usually get through one or two. I also want to state that DHHS is a good partner for Salem Haven and supports us in many different ways. I'd like to point out what all this means in pragmatic terms. The pending Medicaid residents that we're caring for represent almost $800,000 in past due monies. The cash flow impact equates to about $24,000 a week. We always work to ensure we pay our employees and associated benefits, which represent about 75% of our operating cost. We make sure we have food, utilities, medical supplies, and always are meeting our regulatory requirements. Oftentimes, may I continue for a few minutes?
You can finish it up shortly. That would be
one more paragraph and I'm
Yep.
done, and thank you, Mr. Chairman. Oftentimes, we pay bills, I would refer to it as whack-a-mole payables, meaning we pay what vendors, the poorest vendor or who has cash flow issue themselves. To put things in perspective, in this year we'll spend $370,000 in food, plant operations $519,000, and employee benefits, not salaries, $1.5 million. I appreciate SB 131 being proposed, and I hope it is a pathway forward toward resolving this challenge for Salem Haven and other New Hampshire providers. Respectfully, and thank you for your time, and I'll be happy to take any questions.
Are there any questions of the committee? No, thank you very much.
Thank you.
David Chorney.
Good morning, David Chorney, Deputy Medicaid Director.
Good morning.
Thank you for letting me be here today. I'm just here to provide information to the committee if there are any questions. And I appreciate your point about the appropriation. Is we're happy to work through that on finance. And I think the fiscal note was sent in last night. So you should all have it today or soon.
It's like going to be a Christmas present, right?
Yeah.
I don't know what it's going to say. I haven't seen it yet, but I don't have any questions at this point. Does the committee have any questions, or did you want to speak to it?
I have one. What's the ballpark on the fiscal?
So we assume that around 50 to 60% of nursing facilities would take advantage of the provisional eligibility opportunity. And to start up the revolving fund, we estimated that would be about $20 million.
That's it.
All right. Don't focus on the focus on the policy.
Yeah,
yes,
yeah.
Senator Long.
Yeah, so that $20 million is reimbursed.
Correct. Yeah, we see this just as the Nursing Home Facility Association, the senator represented as a revolving fund. So monies paid out would be repaid. And then if the Medicaid application was approved for the individual, Medicaid would make a payment to the nursing facility at the Medicaid rate. And that payment would have it's the general nursing facility rate that has the state funds and the matching federal funds.
Okay, great, thanks.
Yep. I think the only nuance could be if a facility went bankrupt. But I do think this bill would help with a lot of the cash flow issues that facilities are currently facing that could lead to that.
And it could prevent bankruptcy.
Right, exactly. That's what I'm trying to say.
Absolutely. Senator Birdsell.
Thank you. Thank you for taking my question. So this is money, I know it's a big startup cost, but this is money that they would be getting anyway once they were approved. So
Correct. Yep. If
so
the
it's pay
applicant.
now or pay later.
Yep.
Okay.
Not all of the applications that get provisional eligibility will ultimately be approved. Some of them do get denied because they're not eligible for financial reasons or they don't meet the income test or the resource test. But there are a large number that are ultimately approved.
But those that aren't approved, they would have to pay back.
Yep. That's
Okay.
correct.
Thank you.
Any other questions? All right. Thank you very much. Anyone else that would like to speak on Senate Bill 131? With that, I will close the hearing.
Does it need any amendments or anything, right?
No, it's ready to go. Want to do it? All right.
No.
No?
We get to
Yeah, we have two more bills. I'm all for it. Let's get this thing done. Have you seen my book here? All right. Open the hearing on Senate Bill 130. Oh, that's mine. Oh, all right.
I will ditto what you said.
I just told you, I don't know numbers. I know, I kind of get the gist of it.
Mhm. So we're going to open up the hearing on SB 130 FN, and we'll hear from the prime sponsor.
Thank you, Mr. Chairman. And for the record, my name is David Rocher. I'm Senator from Senate District 1. If you get to Romney and keep driving north till Canada, that's my district. So it's big and it's beautiful. Before you have Senate Bill 130, but on February 5th, I distributed a replace all amendment that you have. And this amendment comes because I know this issue is being discussed and worked on in other bills in the House and in the Senate. However, the issue of emergency medical services in the state of New Hampshire is an acute issue in my district, and it's a complex issue in my district. In my district, Senate District 1, we have emergency medical services that are being provided in an array of in a number of ways, everywhere from union shops with full-time firefighters to full-time employees that are non-union to volunteer associations and everything in between. And the concern that we have is we've lost some services in the North Country, and we're being threatened with losing more, and again, for a variety of reasons. So what the amendment does is it works to establish a commission to study delivery models for emergency medical services. What works in Cheshire County, for instance, may not work in Coos County. What's working great in northern Coos County may not work well in northern Grafton County. So the purpose of this is to put a commission together to really understand what, if anything, the state has involved, has a role in this. And I think there probably is a role, but as I understand, the role is, as soon as you define the role, there's something else that comes up. So this really looks to take a comprehensive look at that. If you look at section 1, paragraph 2, lines 14 through 31. It gives you the breakdown of who is going to be involved in this, and everyone from the Fire Chiefs Association to the New Hampshire Hospital Association to the New Hampshire Association of Counties. So the goal is to really get a comprehensive look at the issue, what the issue is around the state, and perhaps some solutions to some common problems that we're seeing. So I want to thank Senator Prentice for helping me out with this. She put in, although your name is not on this, you put in a lot of work to help me get to this point. So I thank you for that. And with that, I'll hand it over to the committee.
Thank you, Senator. Questions from the committee? No. So this is a replace all, and it turns in the original bill into a commission.
Yes, that's exactly what it is. Yep, that's exactly what it does.
Good.
All right, thank you.
And so I'll wait for the chair to come back and make a decision on time limits.
Yeah, we can 2 minutes, just like we did before.
Yeah. So you're up.
Yeah, so we're going to be, in respect for time, we're going to limit speakers to 2 minutes, as we've been doing for the last couple of bills. So with that, Ed Walker.
Issue of time, I'd like to have Chief Starr come up also.
Absolutely.
Representing the Fire Chief Association. We're not going to go for 4 minutes. We understand it's too.
All right.
Good morning.
Good morning. Yes.
Red.
Red, yep.
Good morning. It's still. My name's Michael Sita. I'm the chief of the Tilton Northfield Fire District. I'm representing New Hampshire Association of Fire Chiefs, and today my colleague, you want to?
Ed Walker, Fire Chief in Town of Peterborough.
And we're not going to read our testimony, but we're here really to basically say that we're in favor of stopping balance billing, but we need to have an appropriate reimbursement from the insurance companies so that either, because if we don't, we're placing more of a burden on the taxpayers, or if we don't, we have to reduce our services. And we're both here happy to answer any questions you might have. That's the crux of it.
And one other additional benefit, although these bills only address the commercially insured in New Hampshire, it does set a statutory rate for ambulance service in the state of New Hampshire, which will help us in our conversations with other insurers that we are billing and don't believe that we're billing at a fair and equitable rate. So by going through a legislative process and establishing that fair and equitable rate for the state of New Hampshire, that will help us with the remainder of the patients that we're billing also.
Great. Thank you. Any questions of the committee? Oh, you guys got off easy.
All right.
Thank you.
Thank you.
Paula Rogers.
Thank you, Mr. Chairman, members of the committee. For the record, my name is Paula Rogers, and I'm here on behalf of America's Health Insurance Plans. So the bill is now, I have not had a copy of the amendment, so a commission, I think, is an important step. I think it's, there's going to be an ongoing, no matter what happens this legislative session, there'll probably be ongoing discussions that need to occur. It's hard not to address in this bill what is also in the other bill, and I don't want to take time. I know time is short, but I just wanted to express the fact that the air is a little different this session. You know, you've got bills coming over from the House side, you've got bills here in the Senate, and there are people behind me and various constituencies very interested in some sort of a reasonable solution. Whether it escapes us this session or not, I don't know, but I just want to express the fact that one of the problems that we fear is that we will enter into a system where there is rate regulation, which will wipe out the importance of a managed care product and probably discourage contracting. And so the contracting issue is very important to carriers who are trying to keep rates that are reasonable and reimburse in a reasonable fashion. Now, other states have made adjustments and gone to a rate setting and using Medicare as the touchstone. And we know on this side, the bills are coming through at 325% of Medicare for reimbursement. And on the other side, there are some that, one or two that have 325, but there's one that has a department study beneath it, which has a different and less generous basis for an adjustment on Medicare, 200%. Whether there's some give in between those, I don't know, but this is not going to go away. And I just want to make sure that you understand that the plans want to be productively involved in the discussion. We are, as insured members, the people behind us bill a number of carriers that are either self-insured or out of the state. The insured commercial population for our companies is a very small percentage of their business. And one of the concerns is that somehow the inflationary pressure on their reimbursement to ambulances is sort of unevenly applied. We're an opportunity for a rate increase. You see us there. It will have impact on consumers and plans as well. And we just trust that the discussion will be open-minded and that a solution will come to the fore that, while all may not be comfortable with it, it is a compromise that is acceptable. So in that vein, I just would like to waive speaking on the other bill, except to point out that in both bills before you, before the amendment to this one, there is also House Bill 725, I think it is, it's Representative Stringham's bill. He has some provisions around claims payment. That is sort of a subset of an issue here, and it's replicated in these two bills. plans have prompt pay requirements already under statute. And we would like the opportunity, if that discussion goes forward, to make sure that we're aligning the prompt pay requirements in a way that makes sense. That ambulance isn't so atypical that it becomes a system challenge. So that's the other part, the part of both of those bills I
Thank
think
you.
needs to be mentioned in brief. And so
Thank you very much.
that's kind of where
All
we
right.
are.
Any questions? No, thank you. Sorry to put you on a time limit today, but we got 9 minutes to go here. Sabrina Dunlap.
Thank you, Chair Rochfort and members of the committee. My name is Sabrina Dunlap. I'm Senior Director of Government Relations for Anthem. I will be very brief in light of the amendment, which I also have not seen, but would be very interested in being part of conversations we have historically been at the table trying to figure out, thank you, trying to figure out solutions to this challenging issue for ambulances. And so I have more to say, I think, if the other ambulance bill is still coming forward, so I will be very brief here, but would just say we're happy to try to continue to be part of the solution here.
So I just have a question for you. If we add, and actually my colleague here just pointed out that I neglected to put on a representative of the insurance industry on the study commission. How would you like that worded so that just a representative of the insurance industry?
Thank you for the question. I think typically AHIP is listed, and sometimes, like, I have sat in as sort of the AHIP rep before on other committees. So I think that's how it's done in other bills. Thank you.
All right, we can do that. Thank you.
Thank you.
Questions? All right. Anyone else that would like to? Oh, Michelle Heaton, have you on the list?
Good morning, Michelle Heaton. I'm with the New Hampshire Insurance Department. I'm the Director of Life and Health, and I have here with me Alex Feldavel, and we're going to speak briefly about the ambulance issue.
Thank
we
you.
also just filed a bunch of written testimony for you.
So we'd like to start by just speaking in broad terms about both bills and about House Bill 316, which is on the other side, coming your way. And just talk about basic principles for how we could move forward to a good solution here. The two issues, primary issues that all these bills are trying to solve is the problem of balanced billing that is affecting a significant number of households in the state, and the problem of the inadequacy of funding for ground ambulance services in the state. So those are the two main issues. And there are four principles that we think are important to stick with as we approach how the solution unfolds. One, obviously, that we should end balanced billing. Two, that payers should be reimbursing for full costs for ground ambulance services. Three, policymakers should not cost shift onto commercially insured consumers. That is, each payer should pay their fair share, but we should not be cost shifting onto the commercially insured. And that the cost-based fee schedule that we're all sort of aiming toward should be based on evidence and not be a number that we're just guessing at. So that approach is something that the insurance department was led to when it convened in the summer of 2023, the ambulance summits. And you have the report that came out of those summit meetings that happened throughout the summer of 2023 in the fall. And we had good participation from ambulance providers of all sorts, from carriers and hospitals. What it led to was Senate Bill 407 that passed last year, which required that a cost study be done so that we would have a factual basis for a reimbursement schedule. That study happened over the summer and the fall. PCG was the entity that carried out the study, and it made good use of Medicare survey data to come up with their results. And as you've heard, the results are a fee schedule that is approximately 200% of the Medicare rate, designed to cover costs.
Great.
So there, we had some technical feedback on the underlying bill, but in light of the amendment, we can reserve that for the
That'd be
next.
great. Thank you. Thank you
Any
very
questions?
much. I don't see any. Thank you. Anyone else that would like to speak on Senate Bill 130? And with that, I'll close the hearing. We can probably put that. All right. We're going to open the hearing on Senate Bill 245. And with that, I recognize Senator Prentice.
Thank you, Chair Rochford, members of the HHS committee. I know we're tight on time, but I will move along on setting the framework for this discussion, not just today, but continuing throughout the session. For the record, my name is Suzanne Prentice. I am the state senator from District 5, covering a large part of Grafton County, part of Sullivan County, and one beautiful community in Merrimack County, New London. I'm also a former ambulance administrator, former chief of emergency medical services for the state of New Hampshire, and currently a paramedic. So I add that as background for this discussion today, and it feels like, well, this is Groundhog Day. We're back at it. So I have, with affection and respect, named this bill the Emergency Medical Services No Surprises Billing and System Stabilization Act, because that is what I am proposing that we do here, that we prohibit balance billing, that we, and in doing that, we work to stabilize the system through agreeing on a process for, or agreeing on a reimbursement percentage or rate, and asking our private insurance carriers to lean into the solution, as some of them have said they're willing to, but it's how far we're going to be able to get into leaning into the solution. So let me just say a few things that we are, this is all about consumer protections. So prohibiting balance billing, we've never been against that. I've never been against that. In fact, in 2020, when the federal government passed the No Surprises Act, they exempted EMS from that and set up a committee through the Center for Medicare and Medicaid Services, which was called the Ground Ambulance Patient Billing Committee. You look it up if you're interested in reading the recommendations that they put together. But what Congress recognized in 2020 is that emergency medical services is a complex system. How care is delivered in Cheshire County, as you heard our chair of state, is going to be different than in parts of Grafton County, whether it is career fire, whether it is volunteer fire, whether it is delivered by a private ambulance service. But at the end of all of that, the way that taxes and, underwrite, a majority of this, and the complexities of billing for all these different models throughout the country is why the federal government said, or Congress said, we're going to exempt this. We're going to put this to a group of experts. We'll let them write the recommendations and submit them to Congress. They have been submitted to Congress. And the language in here largely reflects what's been submitted to Congress, because I believe that there are many things that we can agree on. Okay, so the high points on this, again, prohibiting balance billing. 2, we need to have a way for emergency calls. So somebody calls for help, whether it's 911 or they're using another digit phone number, or somebody calls for them, or they are in need of an unscheduled transfer from one hospital to another for care that's not available at that hospital. It's an emergency. They should not have to worry whether they're in or out of network. In an emergency situation, we should be relying, we should take that off the table, because that is another consumer protection that is built into this. I'm asking that for those situations that we work with 2 guardrails, and it's an either or. Either respect the rates that were set by the towns and cities, because when the towns and cities set their rates, they do it in a public venue. They are set by ordinance. There are elected officials who review the rates that are being set based on the model that community has chosen, and they raise their hand yes or no. So we have a publicly set process, or 325% of Medicare. which is not a figure or a number that's been magically pulled out of the air. This actually is a number that was not only talked about when we were working on the federal recommendations, but out of 14 states that have adopted a No Surprises Ambulance Billing Act throughout the country, 6 of them are using 325%. They have been able to find that magic middle. It's somewhat new to these states, so not all of them have it completely worked out yet, but this was not magic. And if you remember last year, we started at 400 and we came to 325, really looking at what other states were doing. So I want to point that out. So prohibit balance billing, take the consumer out of the middle of, how, whether they can get an ambulance or not when they need it, whether it's outside of the hospital or it's inside of the hospital. Respect the guardrails either set by the towns and cities in a fully transparent process, or pay 325% of Medicare. And then I've actually put this at $100 for a copay out of the consumer's pocket. This is exactly, it's one of the other pieces that aligns with the federal recommendations, again, as a protection for the consumer. Okay, I want to point, so those are the high points of this. I want to respond, and I think others may. I appreciate, Senate Bill 407 was fully amended into this actuarial study, which the Department of Insurance, working with many EMS agencies and the Department of Safety in the state, ushered through the process. And, they have come up with a number of, I have 197, but we'll say 200%. But at that, unless I'm reading something wrong, when it starts to talk about what this means per member per month, that's 0.36 cents. So we hear about the upward pressure on premiums for not just the employers, but for those that are that are the employees that are using their benefits. 0.36 cents a month per member. I think it's pretty reasonable. And then we could start to work our way up to what that might look like if it was 325% of Medicare. So I think that is also part of the discussion. I do want to point out Colorado, Indiana, Louisiana, Mississippi, Oklahoma, Texas, and Washington State are in the groups that have picked 325%. Actually, no, all but Indiana. Indiana went with 400%. Okay. The state of Maine, right next door, they went with the 200%. And because this didn't work for them, and this is well documented, thank God for Google, and I'd be happy to share articles with you, that because this didn't work and it actually brought, it started to impact ambulance services where they're, less available, workforce issues because of pay, not able to answer emergency calls in a timely manner, as well as transfers. The state of Maine stepped in with general funds to help actually stabilize the system. I think we can avoid that by getting everybody into the mix here. And I will close, and when I say everybody, I'm talking about municipalities, and I am talking about the municipalities, I'm talking about the private insurance carriers. We also know that New Hampshire, this body in the last 3 years has acted very, in an assertive manner, protecting and moving Medicaid forward to actually get us to 100% of Medicaid for ambulance reimbursement for the first time ever. And it was the first even change, it was the second change in 17 years, but it got us to 100% of where we need to be. We also passed a bill that provides reimbursement that has not gone fully into effect yet, but for treat and no transport. So we are making steps at stabilization. I see this as the final horizon that we need to get through. I want to share with you briefly, and that in early December, former Senator Gaeta and I hosted a meeting in Warren, New Hampshire, which is in Senator Rocheford's district, because I have Wentworth in mine. Senator Rocheford has Warren in his. 4 towns showed up. Only one in mine, the other 3 are in yours. Elected officials, county commissioners, and a room full of residents who wanted to know if their ambulance service closed, who's going to come help them? If they didn't have the availability, if their ambulance service closed, or what we were hearing from the ambulances, the communities that were there that night, if this continued, who was going to transfer? If you were sitting in Littleton Hospital and you needed to go to Dartmouth because you were a trauma patient that needed definitive care at a level 1 trauma center, would this be done, would be able to be accomplished in a timely manner Now, we know we have a helicopter, but that's not always available because of weather and other calls that it goes on. So I want to take that out of the scenario. So they came together to talk about these particular issues. And what we could all agree on is that there's a number of ways to get at this. One is supporting fair reimbursement from commercial insurers. And that's what we're talking for. And we believe that it's fair reimbursement. And I want to point out that taxpayers are already covering the lion's share of supporting, fire, EMS, fire and EMS operations in their communities. They cover law enforcement too, but law enforcement doesn't run any ambulance services in the state. So any assertions about shifting more of the cost to taxpayers, I think is largely unfair considering what they already pay for now. They are part of the solution, not part of the problem. We need to end balance billing. So we can, we're completely in line with that. But if we're going to end balance billing, we have to close that space between ending that practice and what it actually costs to do the work done. And we're asking again for 325% or town set rates. And then continue to support, this is not included in this bill, but I just want to mention, I think it's important, continue to support EMS educational opportunities. So the Department of Safety, working with the Department of Labor and our Division of Fire Standards and Training and Emergency Medical Services have done a number of things to advance this. But most recently in the last year, used some ARPA dollars, last 2 years, to support what we call earn to learn programs. So paying people to take the courses, paying them while they're on the job, and then turning them, as emergency medical technicians and putting them out into the field. Those dollars have dried up, but there are other efforts that are underway to bring more attention to supporting educational opportunities in this state. And I will close by saying, pointed out before, the taxpayers are in the mix. New Hampshire Medicaid is in the mix. I clearly have made a commitment to working with private insurance carriers, and I would be happy to continue that discussion, but we've got to get somewhere close. We've got to get to 325. We've already moved from 400 down to that. And I also, for the record, want to make it clear that I'm not opposed for ambulance services going in network. That's between them and the carriers. And that is a process that is protected. It's not open to everybody. I never tell anyone not to go in network, but here's what we have right now. We need to end balance billing and we need to stabilize our EMS system in the state. Thank you for taking my testimony. I'd be happy to answer any questions. If I don't have the answer, I'll get back to you. I think there's other people in the room who want to talk who may have more information than I do. Thank you.
All right, any questions for Senator Prentice? Seeing none, thank you.
Thank you very much.
Ed Walker. Yes. Yeah, and again, out of respect for time, we're gonna be on a timer again today. I'm sorry.
Sure. Again, we already given testimony for both articles. We've submitted that. And again, we want to make sure that we're not transferring more of this onto the taxpayers. In the study that they did in the New Hampshire Insurance Department that commissioned by I forget the name of the group, professional consultant group, they maintain that the taxes that are being paid now are going to continue to support that at a level that they're continuing to support. So they're still relying on a high level of taxpayer input on their reimbursement rates rather than the insurance companies who could pay their rightful share should be paying for the rightful share and still not offsetting that cost to the taxpayers.
Thank you.
One other final thing to highlight, as was discussed earlier in Senate Bill 133, which you all unanimously voted as ought to pass, was really the identifying the identifying the emergency medical technicians as first responders and creating that as an essential service. To echo what Senator Prentice said in the study that she talked about for Maine, New York, and Vermont also provided similar studies, blue room panels, is we are starting to fail our residents in EMS. Nationwide, there is a significant decrease in the capacity for emergency medical services delivery. And although as a fire chief, you never say babies are going to die, there will be negative outcomes. And I think it's important where we have an opportunity now with everybody at the table really looking to delve into this and solve the problem, coming up with a system that will ensure the residents of this state have access to the appropriate emergency medical care when they need it.
Thank you. Any questions for the chiefs? No, thank you very much. Thank you. Michelle Heaton.
Hello, Michelle Heaton from the New Hampshire Insurance Department. I'm Director of Life and Health. I will defer back to our written testimony that we filed for the prior bill. As directed, we did assist the New Hampshire Health Plan in contracting with PCG to conduct that cost study. That cost study collected information from the ambulance providers, and the rate they came up with is what would be the rate to cover costs, assuming that all payers paid that rate. So I just wanted, I know my time's short, so I'm just going to dive into some of the technical issues with the bill as written. There is a fiscal note we prepared, and the fiscal note was prepared by the actuary who assisted in the cost study so that the analysis is the same as that cost study. And it was estimated that this rate could, in aggregate, cost at least $15 million more, which equates to roughly $1.13 to $1.38 per member per month increase in premium overall. Part of that is because you're setting a floor for a rate at 325. We would say that is the floor because there is the ability for local entities to have higher rates if they so demand. So that would be the minimum it gets set up. So we would estimate that would be the minimum fiscal impact. Another part of the fiscal impact here is setting the cost sharing cap at $100. Those costs need to be absorbed in some way. So when we're talking about the actuarial value of the metal level plans, so we're talking about your bronze, silver, gold, platinum plans, there's a certain actuarial value associated with that. So if you take away cost sharing from one service, that needs to even out in some other way. So by doing that, sometimes you're going to cause inadvertently, cost sharing for other services to have to go up to maintain that actuarial value of that metal level plan. So we just wanted to make sure you're aware of that. Also, there's some concerns with page 2, section, or starting with paragraph 5, when we're talking about the prompt pay and clean claims. I think there is some confusing language in here, and I'm not sure how we would be able to operationalize it. We do already have prompt pay laws that would apply to these services. These set a different standard, which would be difficult to operationalize, and it also requires that a clean claim be paid. By definition, a clean claim means that, sorry, I think I said that wrong, that if it's not clean, that needs to be paid. If it's not a clean claim, that means that the necessary information to adjudicate the claim is not there. So I'm not sure how that would work. If they don't have the necessary information to process the claim, how could they possibly pay the claim? So I think there's just some cleanup that needs to be done there. And we would suggest mirroring that with the prompt pay law.
That's what I was going to ask you. All right.
And then the next paragraph, so paragraph 6, I think what this is getting at, where it's talking about having it identified as ERISA or non-ERISA, I think that's the incorrect terminology. I think what is intended here is to identify whether it's a fully funded or a self-funded plan. We could require them to identify that it is a fully funded plan. However, we have no jurisdiction to require a self-funded plan to identify itself that way, and that could be a potential conflict with ERISA. So I think that paragraph would also need some cleaning up as well, and I'm happy to take any questions.
Are there any questions? No, thank you very much. Yep. Chris Kennedy.
Thank you, Mr. Chair. For the record, Chris Kennedy, Vice President of External Relations for Centene and Ambetter Health Plans. I know my time is short, so I will address really 3 or 4 top-line concerns with the plan. And first, let me just say, I applaud the effort here. I agree with Senator Prentice. We need a resolution on this. I'm certainly not going to sit in front of you and say there's not a problem. I have some concerns with the policy remedy that's proposed here, and I also do think there's a better policy remedy of all the ones I think you're going to consider this session. But just with respect to the bill at hand, first of all, 325%, setting that rate as a floor. If we're going to do commercial rate setting, I do think there should be some cost-based analysis analysis that's tied to it. This legislature did direct the insurance department in the study that Michelle Heaton just mentioned just last session to undertake such a cost analysis. The consultant was procured for that purpose. It's a 45-page report. I think it's very thoughtful, fairly exhaustive, analyzes existing market trends. And again, I think it would be a shame if all that work went to waste. It is something that I think should be considered in the overall resolution of this issue. I represent a smaller individual market only health plan. We have about 25,000 members in the state. About half of those members already receive a federal subsidy towards payment of their premium. So it is a very price sensitive market, very price sensitive consumer. So the cost impact, when I look at $15 million of essentially a commercial ratepayer surcharge to cover the whole of this problem, I ask the question of fairness on that. You're really only looking at, taxing, surcharging, putting this burden on to about 30% of the overall commercial population. And whether or not that's really fair, I think Senator Prentice referred to the term commercial payers should pay their fair share. I think my consumers, my members, would consider their premium payments as their fair share. The issue of network did come up, and I appreciate that Senator Prentice identifies that as an important consideration in this overall. I will say, if you set a floor negotiation rate at $325 with a cap on cost sharing, what incentive is an ambulance provider ever going to have to come in my network? We're not even going to have the conversation if they can get that deal outside of network. So I actually consider that a disincentive towards network. And the only last thing I will do, rather than regale of all my grievances, is rather say I think Senate Bill 3 or House Bill 316, when it does come before this body, is a really thoughtful approach at doing this. It sets a rate that I think will ultimately result in a net increase for ambulance providers, and it puts some analytical infrastructure around that. It allows the insurance department to amend the rate with market dynamics in consideration. I think it's a really thoughtful approach towards that. And I would certainly prefer that. I think consumers, I know my members would prefer that over setting a rate of 325%. That does represent, again, I think a fairly costly surcharge on commercial policyholders.
Great, thank you. Are there any questions?
Just
Senator?
one real quick. You said House Bill what?
House Bill 316. I think I have that right.
Thank you.
I do.
Next, are there any further questions? No. Next speaker I have is Chris Stawen. I don't know if I pronounced the name right, but you know who I was talking about.
Yes, sir.
So.
Stay was. Thank you. Good afternoon now, I guess I should say, and I'm going to keep it to 2 minutes. Thanks for the opportunity to speak today. My name is Chris Stawas. I'm on the board of directors for the New Hampshire Ambulance Association, and I reside in Hollis, New Hampshire. I've been a nationally registered paramedic in New Hampshire for the last 40 years, and I've been involved in running municipal systems throughout the state. Senator from Manchester knows that very well. The New Hampshire Ambulance Association supports Senate Bill 425. It would end the need for balanced billing by ground ambulance providers in New Hampshire once and for all and protect consumers from surprise medical bills. We are completely in support of that, have been since day one. As important, it would also fill the revenue gap that would be created by ending balanced billing, hopefully preventing additional ambulance providers from closing their doors and putting further pressure on an EMS system already in significant distress. There are currently 3 House bills in the House Commerce Committee that are attempting to also accomplish this and solve the problem of over 80% of New Hampshire ambulance providers not being able to afford to be in network due to low reimbursement and one-sided regulations. Senate Bill 425 provides several important protections not seen in the other bills. Senator Prentice has already mentioned them. It caps co-payments at 100% for patients, which I think is huge. It prohibits insurers from requiring pre-authorizations for emergencies or unscheduled ambulance needs. And it also requires insurers to reveal the type of plan, you've talked about it earlier, and Ms. Heaton mentioned it, ERISA versus non-ERISA, or funded versus, fully funded versus partial funding. Last session, despite our best efforts to pass similar language, Senate Bill 407 ended up requiring the ground ambulance cost study to be completed to determine the actual cost of providing ground ambulance service in New Hampshire. That study was fully funded by the New Hampshire Health Plan and its member insurance companies. It statistically proved that New Hampshire's ambulance services are currently reimbursed below cost by commercial ambulance providers, as well as New Hampshire Medicaid and Medicare. By choosing to continue to reimburse New Hampshire ambulance providers below cost, the commercial insurance providers of New Hampshire continue to force ambulance providers to balance bill patients so they can attempt to recoup their operating costs. They have done this to try to entice ambulance providers into their network for the last 20 years, but as you've heard, 80% of them are not in network, so it is not working. The state insurance department has been unable to determine the amount ground ambulance providers collect by balance billing. The ambulance study report expertly details the actual costs of those services. However, for all its analysis, it also fails to determine or reveal the actual collected balance billing amount. And that is the absolute heart of this matter. I know I've gone over my 2 minutes, so I will look forward to working with the members of the committee to work on this. It's a solution that I think we all want to reach. It's a matter of how we get there.
Any questions? No, seeing none, thank you.
Thank you.
Next is Paula Rogers.
Speaking because I spoke previously and it will be very similar.
Great, thank you. And Sabrina Dunlap.
Thank you, Chair Rochford, members of the committee. My name is Sabrina Dunlap. I'm Senior Director of Government Relations for Anthem. We are opposed to SB 245 for a number of reasons. I will try not to repeat what Chris Kennedy already shared. I will say the insurance department pointed out, I think, every single technical issue I had with the bill, particularly around, it's actually unclear to me if balance billing is actually banned under this bill, and it's due in part to the language under 1A and B, because it appears to me that a member's deductible and coinsurance and copayment are all still at play because it says accept. Anyway, it's just something I raised because I actually was confused by that language, although Senator Prentice said that was from the federal guidelines potentially. So, okay. So I will take another look at that, but it was just something I wanted to flag because it does get into benefit design. I think, you know, we've been talking about this for a very long time, obviously. And Anthem recognizes the unique challenges facing ambulance providers, and we do know something needs to be done. My worry is that, again, this sets a floor of 325% of Medicare. And to Chris's point, I worry, why would an ambulance ever come in network if they can just stay out of network and have that rate? And it really undermines the cornerstone of managed care, which is insurance companies have networks for a reason. We have them for the benefit of our members. And so this really sort of creates this out of network sort of model that worries me. I think we should be cautious about going down that road. And I just also want to point out that, yes, this is a large problem. And I will say I'm on my town select board, so I totally appreciate the municipal perspective and the burden on taxpayers. But when thinking about the pie of ambulance, the fully insured market is a really small piece of that. And I know others have said that, but this bill really gets at just that segment. And it puts further pressure on, you know, that piece of the pie. So I would just be aware of the cost of this on a small section of that pie. I caution us moving in the direction away from the cornerstones of managed care, and also very happy to continue to be part of the conversation on this important issue. So thank you very much.
Any questions for Sabrina? No, seeing none. Is there anyone
you.
else that would like to speak on Senate Bill 245? Come on up.
Good morning. Thank you for giving me the opportunity to speak for a minute. My name is Nathan Borland. I'm a critical care paramedic here in the state of New Hampshire. I've been a paramedic here since 2010 or 11. I have a total of about 25 years experience. I'm here today as the vice chair of the New Hampshire Ambulance Association. I have extensive experience throughout the state in multiple roles as a paramedic, as a chief of a department, and other things. So when I speak to you about this, I'm kind of coming from a slightly educated perspective. I wanted to speak up. I wasn't going to speak initially until a couple of things were brought up. This study that keeps getting referenced is a very flawed study. And I say that because what it looked at was costs spent during the time frame of the study. That was already a bare bones, we're just barely getting by and ambulances are failing list of expenses. It was not a, hey, we're having steak every night. This is, no, we're having ramen noodles every night and then wondering why we're unhealthy. So keep that in mind when you look at this study. That is not a sustainable number that they've come up with. It is, this is what we're doing to scrape by right now while we're looking to you to fix this problem. And with that, I'll be happy to take any questions that I can answer for you.
Any questions? No, thank you for your testimony. Last call, closing the hearing on Senate Bill 245. Do we have time to do anything? We want to go get lunch before.
I'm not sure yet. We go caucus at 1, so.
All right.
But if you want to go to if he chooses, if everyone else votes for it, then I can get it.
I'm gonna go for it.
I like John as a person, but I'll tell you.
Hey, do we want to?
Move to go into exec?
I got a motion to move into executive session. Do I have a session? Second. All right.
By community mental health centers to hold on 122 because they are going to be meeting with the insurance commissioner coming up. Let me just quickly look.
No.
Okay.
Text messages. So hang on, I will. I just want to make sure we did that. No, it's 136. Oh, sorry. Chair Rochford, if we could hold on doing anything with 136, which actually isn't even on
It
our
wasn't
list.
even on the
Oh,
list
okay.
here.
I was,
Yep.
okay, I was jumping ahead. Thank you, bud. All right.
Just quickly looking at the bills that we had today, is there any,
1:30,
130?
move out to pass.
Wait, hold on. Oh, sorry. Okay,
130, I got a motion ought to pass. Do I have a second?
second.
Motion and a second.
We need a committee amendment?
Yes. We're gonna adopt the, I think we're gonna adopt the amendment.
Yeah.
that I put
Oh,
forward.
okay, that amendment and then
But
a
then
committee amendment.
we want a
to that.
committee amendment, that one,
All right.
yes.
Right, so I move amendment 0273.
Yep.
Need a
Uh-oh.
second.
Everybody's discombobulated.
I know. Senator Avard moved amendment 0273.
I'll second it.
And then Senator Long seconded that.
Which stuff?
That's the amendment.
No, I mean, I just have all my.
Yeah, I know. I'm with
So-
you.
My little vote here, it's not good.
Something that, so do you want to speak to your motion?
No, I like it.
Okay. I think one of the questions that came up is perhaps speaking to Senator Birdsell is we probably should have a representative from AHIP on that commission.
That was gonna be the committee amendment I was gonna.
Okay. Yep. Go for it. So we have the motion on the amendment. Do we now
Now this is like a sub amendment.
Yes. How do we?
It's an additional.
How do we do that?
Committee amendment.
Yeah, if you want to, instead of voting on this amendment as is, you could just make a motion and vote on a committee amendment that's reflective of this with.
Whatever changes.
Okay.
So move to make a committee amendment on 0273 by adding.
So we have a motion and a second on the floor. Do we need to withdraw that?
No.
No? Okay.
Wait a minute, I think you just said yes to be safe, you said no.
Let me see. No, you can amend
So
the amendment.
we can't approve this amendment as amended.
Oh,
We're gonna do a committee amendment, so the underlying bill, this is gonna replace the underlying bill. Okay, and then we're gonna take that amendment and put a committee amendment in to add a representative from the insurance industry to that commission.
We're basically going to add language to this amendment.
right.
And make that a committee amendment.
So we can approve the amendment and then add a committee amendment to it.
Add language to it.
Correct.
Yes. I think.
So we should vote on the amendment.
Yep.
And then make a committee amendment to the amendment.
So go on a separate committee.
Correct.
Okay, yeah.
Yeah, that makes sense.
Thank you, everyone.
So all.
So any further discussion? All those in favor, say aye.
Aye.
Any opposition? Okay.
Well,
Now I propose it. Go ahead.
the only other thing I thought about on is not just adding someone from the industry, but should we have the Department of someone from the Department of Insurance on there?
Isn't that it?
No, AHIP is not.
A's the health
Yeah,
plans.
sorry.
Oh,
Yeah.
my apologies. Yeah, you're right.
I mean, you can bring it, granted, the commission can bring them in for,
That's true too.
Yeah.
it's up to you guys.
Keep it simple.
I think if we, to your point, I think if you're right, I think we can put AHIP in there and then the commission can bring in the Department of Insurance.
You know, the only other thing that I'll offer is that, and we could pass this as is and do a floor amendment, because if we're gonna add the Department of Insurance, we should add the Department of Safety.
They're in
because
there.
They are. Did I put them in there?
I think they're in there, yeah.
Yeah, that's not, it's letter C.
All right, I'm sorry. I've been too focused on 245.
You want a
Sorry.
motion to put in AHIP
Yep.
as,
A member of the
as a committee
member
amendment.
of AHIP.
So just make sure I have it right, because I have to give OLS the exact language, if you want to do that, like after,
The HIJ.
J, yep,
so
yep.
Needs a second.
So we've got a motion from Senator Avard to add that. Do we have a second?
Second.
All those in favor, say aye.
Aye.
Oh,
Opposed?
A motion
No.
to approve as amended.
So
Second.
approve as amended. We have a second. All those in favor, say aye.
Aye.
Opposed?
Consent?
All right. Consent, yes. Motion for consent.
second.
Okay.
All right. All those in favor, say aye.
Aye.
Opposed? No. All right. Very good.
You gonna take it out?
I can take
Sure.
that out. Yeah,
Sure.
I can take that out.
To make a motion on 131.
131.
Motion ought to pass.
Wait a minute. Are you ready, Sophie? All right. Let us know when you're ready.
Oh, wait. 131?
That's the revolving fund for nursing homes. That was today.
The provisional. Yeah. Okay.
All right. So
Makes total sense.
Senator Avard made a motion, ought to pass. Do I have a second?
Yeah.
Senator Prentice seconds. Any discussion? All those in favor say aye.
Aye.
Opposed? No. Motion to put on consent.
So moved.
Second.
So we have, and I got a second. All those in favor of putting on consent, say aye.
Aye.
Opposed? No. And I'll take that one out too. So Senate Bill 120, there's an amendment, that's the biomarkers bill. There's an amendment from Senator Innes in there.
120.
Yep. Oh, they did. I haven't seen that.
I didn't hear you. I'm sorry.
Okay.
Well, then it's not.
It's not ready.
Okay, we're gonna hold off on that one then, if there's another amendment that we need to consider. 122, that was the one that, you said 136, Senator, that we're gonna hold off on. 122, relative financial eligibility for the Medicaid Savings Program.
Can you make a
Feel
motion?
ready to take that up, or?
Is there a change? Yeah, I'm fine. Yeah, I thought there was something, there was a change to it, but, okay.
I'm happy to make a motion if you're ready.
Okay, I'll take a motion.
Senate Bill 122 ought to pass.
I've got a Senator Prentice ought to pass, Senator Birdsell seconds. Would you like to speak to your motion, Senator?
Nope.
All right. All right.
Oh, it's all in the, it's all in the hearing.
All right.
Like, I've given my feedback. I'm good. Thank you. But thank you for the opportunity.
All right. So call the question on Senate Bill 122. All those in favor say aye.
Aye.
Opposed? All right, 5-0.
Overwhelming support.
We have consent, motion for consent.
Second.
All right, I saw Senator Prentice, motion to consent, Senator Birdsell, second. All those in favor say aye.
Aye.
Opposed? No, no, that wasn't an opposition. It's on consent, yes. 5-0. Senator Prentice, you're a co-sponsor on this. Would you like to take this one out?
Sure. Happy to.
All right. Where are we with ear acupuncture?
We got some more, we got an email with some more detail on that. That, and there was one other, looked at it last night because I was actually looking for the fiscal note on the compassionate stay, moms, and that wasn't in there.
So when did we got that? Oh. All right. I haven't read that email yet from HHS. So I'm not ready to move on that. There's new information there.
I didn't get a copy of it. Well, let's just put it this way, it's not in the folder, so Maria will grab it. I'm not ready for
Right.
that either.
Are we ready to talk about Senate Bill 126 relative to notice of changes to provider contracts?
I don't know, are we ready on that? Are you ready to go on that?
There's no changes on it, and,
There was a lot of discussion.
I think it's ready to be voted on.
I'll move inexpedient to legislate. I just feel that we're not in the contracts between providers and hospitals is their business. I'm not sure we're supposed to be stepping into it, but
All right. So I got a motion for ITL. Do I have a second?
I'll second it, and I know it's my bill.
Oh
and
my goodness, you're gonna go down.
Yeah.
Yeah, 126.
Do that.
Any
Yeah.
further discussion on 126? So the motion is ITL. All those in favor say aye. Any opposed say nay.
Consent.
We'll move to consent. All those in favor of consent say aye.
Aye.
Opposed?
I know.
Oh, maybe I didn't even get a second.
I seconded it.
You did?
No, you made the motion for consent.
I'll second.
Oh, on consent, you mean?
Yeah.
Oh, I apologize. I didn't hear it either.
I'll second.
Senator Birdsell, do you want to take this one out?
Sure.
All right. All right. I'm waiting for information on that. He said we're not ready for 128. So, are we ready to talk about prosthetics?
I'm ready to talk about it. I'm not ready to vote on it yet.
I'm ready to talk about it, but not to vote on it yet. So Senator Gannon, I suggested to Senator Gannon, based on the work that we did on the children's version, that he talked to the Department of Insurance about whether we need an insurance mandate review. I understand that there was some, we heard it in the hearing, it's in the hearing report, they were able to pull some data from that helps with the adult. But the question is, do they need one solely focused on the adult? And then I also talked to Senator Gannon about some of the, I don't call them concessions, but recommendations that we ended up following in passing the child version. He is meeting, as I understand, with Commissioner Betancourt this Friday.
Okay.
So we should hold until that meeting takes place.
Okay.
Yeah, because I talked to him as well, and I said, you need to limit it. Like to one every 5 to 10 years, somewhere in there. Because we can't, I mean, the lifespan they said is 2 to 3 years. I think that's unsustainable.
Senator Brooks, may I?
Yeah,
Senator Brooks,
absolutely.
we did that with the children.
Yeah.
We had a similar provision plus medical authorization.
And plus, if you want one for a sports aspect, then pick a sport. We're not going to, I don't think they should be paying for it. If you want to swim, if you want to ski, not one for each sport.
And that's, again, with the children.
Yeah.
In working out compromise, that's where we came.
So if we can't get to that point before March 5th, we may want to re-refer that.
Yeah.
It took 2 years.
Yeah, I
We did a
remember you said
re-refer,
that.
and it took 2 years to do the children's and to do
Yeah.
it right. So I think the conversation on Friday will be really informative for Senator Gannon on what he wants to do. And
We won't do anything now then.
Trying to stay
He
close
may
to
want
now.
us to re-refer it.
okay, good.
I'm all set on the public guardian one, if you'd like to do that. I'd like to pass as is.
I mean,
I'm not ready for that one.
we're waiting I want to wait to see what happens after the governor's address on Thursday.
On the public guardian?
We were told that was a prioritized need.
Right.
So I want to see what's in her budget for that. Because that may resolve one of the questions or not. But are we ready for 134 relative to work requirements under the state Medicaid program?
I move on to pass.
All right,
Second.
we've got a motion and a second.
What number is that?
134. Yes, so we've got the Senator Pearl's amendment is 0211S.
I move 0112F.
0211F.
That one too.
Yep.
Needs a second?
I'll second that.
Discussion.
Needs
It's the underlying bill number because my
134.
All right, I didn't see this for today.
Yeah, the
154. And so you've got. Do I hear not a pass motion?
There's not a
All right.
pass motion.
So if I can, I'm not gonna be supporting the ought to pass. Well, let's deal with. We want to deal with the amendment and then we get back to the underlying bill. Thank you. All right, bye-bye.
So the amendment we have is 0211. If you recall, that essentially just adds the component that the waiver is going to go before the fiscal committee of the general court for approval. One of the questions was the date, July 1st.
To move that, we probably should amend that.
Yeah.
To further date.
September 1st?
Yeah. Either that or September or
January
November.
1st.
January 1st?
2026.
January 1st, 2026.
So
So
we pass the amendment and then add the
as a committee amendment, yeah. All right, so I'm going to call the vote on the amendment. The motion is ought to pass. All those in favor say aye.
Aye.
Opposed?
No. Opposed. Yeah.
So we've got, on the amendment, it passes 3-2.
And I would like to make an amendment as to the change of the date to January 1st, 2026.
And I'll second that. So that's on line 5, Sophie, changing it from July 1st, 2005 to January 1st, 2026.
I think that's what I was making. Isn't it? Is that the date?
No, it's the on or before they have to submit the waiver. I don't think we need to change the effective date, because the effective date is effective on passage, and the way I read it, that will trigger the process.
Yeah.
And it doesn't change that January 1st date. Yeah, yep. So the motion and the second is to change the date to January 1, 2026. Any further discussion on that? All those in favor say aye.
Aye.
Opposed?
This is just changing, wait a minute, are we talking about the whole bill or just changing the date?
The waiver date.
The waiver date? Oh. Yeah, if you want to change the waiver date, that's fine.
Okay.
I still am opposed to the underlying bill and I want to speak
Okay.
to it. Yep.
Senator Long, I know you said no. Are you?
No, I'm a yes with that.
Okay.
Hey,
All right.
that
So
was
that
on the whole thing.
I move out to pass as amended.
the committee of, yeah, wait a minute. So the committee amendment changes that date to January 1st, 2026, and that passed 5-0. Okay. Now, Senator. we're
I
ready.
move out to pass as amended.
Second.
We got a motion and a second. Any further discussion? Senator Prentice.
So a few things. I'm opposed to passing this. There's a few reasons why, but in the very beginning of the testimony, the hearing, we heard from the department who doesn't come in favor or oppose, but one of the things they cautioned us about is that there's a new administration and that things are moving rapidly and that we should consider that when we don't know what the landscape's going to look like as it relates to Medicaid moving forward. So I felt that that was a caution I thought it was caution, and I take that seriously. I also believe that this could, and I'm going to point to Jake Berry's testimony in particular from New Futures, because there was a woman that came and spoke to us from Henniker, and she also came and spoke to us when we talked about Medicaid, the granted advantage. And she made the case, as is the case here, that when you have health care and you get better, you're able to go back to work, where there are conditions and situations where not everybody can make that move, and that there has been demonstrated in different states drop-offs in coverage. There's a gap that needs to be filled, and Jake Berry speaks to it pretty nicely about that. This would result in the loss of coverage for many vulnerable individuals. Agrees with the benefit of physical, social, and financial health, but this is only supposed to be short-term coverage. We're supposed to get people to the other side of this. So we could be putting ourselves in a position where, number one, we don't know what's going to happen federally, which is going to have an impact on this. And the experience has been, and I know there's lawsuits and things happening in some other states where it has created a significant drop-off. So that is, I just think there's a cautionary tale there in holding on this. That's my 10 cents. Thank you.
And I will say that it looks like the feds are going to go ahead and we believe that they're going to go ahead and implement it. And number two, it's already on the books. All that we're asking is to submit the request for approval. So.
Okay. So, to one of your points, Senator, as I heard the testimony, I mean, you couldn't help but worry about, oh my goodness, is this going to, we heard a lot of testimony. It was compelling testimony, but I think I go back to the bill itself. This isn't defining the specifics yet. I mean, this is instructing the department to get more granularity in it. And with the amendment that we passed, it still is going to come back to the fiscal committee. So if there's some things in there that are this isn't the end of the line for this. I don't know if that allays any of your concerns, but this is not the end.
Thank you, Chair Rochford. I appreciate it. I'm going to hold my vote, but I will continue to monitor this.
Absolutely.
I appreciate it. Thank you.
All right. Any further
Yeah.
discussion? So the motion is ought to pass as amended. All those in favor say aye.
Aye.
Opposed?
She said no.
Oh, sorry.
Oh,
She said no.
she said no.
It only sounded like I.
I said no.
Oh, so it's 3-2.
I can.
There you go. Senator Birdsell graciously volunteered. 135.
It's
That's
10 of.
Oh my goodness. All right.
We're done.
We were on a roll there, but I think we got a good chunk of work done. So with that,
Motion to move out of exec?
Second.
all those in favor say aye.
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 So motion to
This
adjourn.
time I got it
So
right,
moved.
yes.
All right, we're adjourned. We'll be back here on, just for the committee members, we'll be back
Thank you
here
for catching me.
on Wednesday. We are probably going to be meeting on Thursday as well for a big exec session to get cleaned up.
This Thursday?
No, next Thursday. We're told now, at this point, we don't have session. There will not be session next Thursday.
Okay.
So if you want to do